Good morning to everybody, both here in this room and those online. And a very warm welcome to this public session of the HOMeAGE training event. I will give the floor immediately to the representatives of the two organizations who are hosting the event. And I will start with Associate Professor Elena Spina, Professor of Economic Sociology here at the Marche Polytechnic University. Please.
Good morning, everybody, and welcome to our faculty. We are very pleased and very honored to host you here, and we wish you a great stay. As a member of HOMeAGE, I should have been among you today and the next day, but unfortunately, due to several commitments in this period, I will not be able to attend this training session. And I'm sorry also because I direct an interdepartmental center of research on health and social integration, which is based here in our faculty and which deals with several issues, including issues that you will discuss next days. So aging, of course, but also technologies, professional groups, housing, migration, and so on. So I invite you to visit our website. Unfortunately, currently is under refresh and is available in Italian language only. But I invite you to visit it and to contact us if you think have interests to share with us. I want to thank Giovanni Lamura and Nicole Bronzini for organizing this training session. And once again, I want to wish you an exciting days and a successful interaction. Thank you.
Thank you, Elena. And now I'll give the floor to Professor Antonio Cherubini, who is Professor of Internal Medicine and Geriatrics at the Marche Polytechnic University, and at the same time, Director of the Department for Geriatric Care of Frailty and Care Continuity at IRCA, the National Institute of Health and Science on Aging.
Thank you very much. I also welcome everybody here in the room and online. It's a pleasure to introduce this meeting. I saw a very high-profile program. I'm sure you will really benefit from it, and I hope also you could enjoy the Ancona while you are not involved in working activities. I think the topic of aging in place is extremely relevant. And of course, seeing it from the healthcare perspective, I think it's really an area where the integration of social and healthcare activities should be of paramount relevance. I was last weekend, we presented a document, the Carta of Florence, which is devoted to fight ageism in healthcare. And I think it's extremely relevant also for this kind of activity, because people to age in their place, at a certain point, they develop diseases, they become disabled, so they need a strong long-term care in which social and medical components are both contributing to maintaining their independence in their place. So I think this is a further theme in which we should integrate and collaborate. At IRCA, I mean, we have both components in the institution, and so it's certainly a nice opportunity, but I'm sure that in these 3 days you will have plenty of time to discuss this and hopefully to find, as is the aim of the project, I saw identify evidence-based solution. In this evidence-based solution, I think that the healthcare should have a place. We have evidence that the type of acute care you get changes your destination. So the probability to be admitted to institution is higher when you are having an acute problem and you are not properly managed. And the same is true in nursing homes. So I think this is an area we should certainly collaborate. I again wish you a very nice stay in Ancona and a productive meeting. Thank you.
Thank you, Antonio, and thank you both for representing the two organizations for hosting this meeting. And we can now start our program. And well, in my role as a director of the Center for Gerontological Socioeconomic Research at Italy's National Institute of Health and Science on Aging, and as chair of this session, and also on behalf of Professor Nicole Bronzini, who of the Marche Polytechnic University, which is hosting us today, I'd like to underline that this lecture and training session is likely to provide interesting insights on a topic that is becoming more and more central in national and international political and scientific agendas in our aging societies, and also has a strong impact on aging in place trends, and that is long-term care. We have just heard a few words hinting to the fact that depending upon how the systems are able to deliver appropriate care, these can have an impact on where you are going to age in the last phase of your life. So we will hear about how these systems are working in a comparative perspective. And but before I will introduce the two esteemed colleagues who are going to illustrate recent developments in this field, I will give the floor to Kieran Walsh, who is Professor of Aging and Public Policy in the discipline of economics, Director of the Irish Centre for Social Gerontology at the University of Galway, Ireland, who coordinates the EU-funded HOMeAGE doctoral research program under whose umbrella today's event has been organized. So, Kieran, the floor is yours.
Okay, thank you very much, Giovanni, and thank you, Giovanni, Elna, Nicole, and everybody at the University of Politecnico for the very warm welcome and great support in hosting this event. So there are just a couple of very brief words of introduction and really of context, just to say for today's event. Many of the people in the room will already have heard much of this, but I think just for those online and those who are new to the network, we just want to give a brief sense of where this fits in. So the whole purpose of HOMeAGE is to really institute a training and research program that interrogates what aging in place should mean, that actually challenges what we actually mean for this for different people at different stages of life course, and particularly around people's different contexts and backgrounds and how they've come to actually be in place. So to do that, it is about training and it is about development, and it's a focus on interdisciplinary, intersectoral, and an international elements of that program as well. And that's really what today kind of fits in in relation to what people want to hear and what people want to connect with. So we're obviously focused on a 48-month program that encourages and fosters and supports 12 doctoral researchers to engage in this interrogation, to engage in this examination, but to do that in conjunction with their supervisors and many different associate partners, international organizations, national policy organizations, leading research centers. And I suppose together, we're essentially trying to all learn through this process as well. We are trying to tackle 3 key challenges as a part of this element. So we have a challenge around home and belonging, where we want to harness new engagement pathways as a means to create new channels for building a sense of home and belonging amongst diverse older populations. So that's recognizing the diversity and heterogeneity of older populations. It's recognizing the changing nature of our communities and the changing nature of our population dynamics. And how do we try and plan and support people at different stages in relation to that? We also have a challenge around rights and voice, which is looking specifically at how we identify integrated frameworks that draw in and support in a policy and practice sense that holistic engagement, and also that very rights-focused piece of older people as being rights bearers, and how that comes to bear in terms of conversations around aging in place. And very much so about the recognition of the diversity of different kinds of place contexts and diversity of different individuals and groups. And then we have what is essentially our first challenge, and is the purpose of today, is around needs and systems. And in this context, I suppose we're talking about the full breadth of those needs, the full breadth of those systems, where we are looking at mobility, we are looking at housing, we are looking at digitalization, the intersection of those, and along then with care systems as well. And in conjunction to that, we're also looking about where that fits in at different points and stages of people's lives. So what are the kind of different needs that people have, not just in terms of care and support, but also in terms of enablement, in terms of mobility, in terms of engagement and inclusion. So this is something that we're essentially want to focus on. So what I'd encourage anybody who's first connecting and first hearing of the network is to stay connected. There will be a whole series of these events over the next couple of years. Second one, there's at least going to be another 3. And also just to be aware that there will be outputs coming from the project that might be of interest to yourselves, including academic publications, policy briefs, and various different papers. These are all the media elements that I'm very pleased to say I have nothing to do with. So Christine Delargy manages this, Neil Merrill, Fatima, and several people all support us in terms of doing this, and are doing a much better job than what I would ever be doing. So please do connect in with us. Please do stay connected in terms of your own interests. So then it comes back to today. So today we're focusing on 2 kind of key elements, particularly with that focus on needs and systems. So really today is the first of our thematic sessions with respect to aging in place. So the next few thematic sessions will move on to home and belonging, and then on to rights and voice. But today is focused specifically on needs and systems. So the first session that Giovanni will be chairing in a couple of minutes will be looking at theoretical and applied contributions in aging in place systems. And then later on this afternoon, we'll have a piece on methodological aspects around aging in place research. And again, the focus of today's contributions are picking up on big questions around care, and also some big questions around housing. But both of these point to broader transferable learnings around how we think about our systems, but also how we think about our needs. But that's about the changing nature of systems. It's about the intersectional nature of those systems, where care and mobility, or care and digitalization, or where inclusion meets all of these different pieces. And I suppose from our perspective, we're looking at this in a broader enabling framework of empowerment that looks at recognizing the agency of both people and supporting that agency as well in the context of aging in place. So that's where today's sessions will sit. And I think that's all of it for me. So I'll hand you back to Giovanni, and thank you very much again for joining us.
Thank you, Kieran. We are well in time, actually ahead of time. I hope this is not an issue, especially for those who are connecting online. But this allows me to move to introduce the first of the 2 speakers, who is approaching the podium here. Thank you, Kai. I think that's the place where you can sit. Kai Leixenring is the director of the European Center for Social Welfare Policy and Research in Vienna. And He has a long-standing experience in comparative and applied social research and policy consultancy on population aging, health and long-term care, and related issues such as governance and financing, quality management, labor conditions, user involvement, and informal care. He has coordinated a multitude of national and European research and development projects and collaborated with regional, national governments and international agencies. And since 2016, he represents also the research community at the United Nations European Committee for Europe Standing Working Group on Aging. So you can understand that we could find no better speaker to help us understand the essentials of long-term care systems in aging societies and the key challenges which we are facing in terms of how to assess needs, how to deal with governance, funding, service delivery, and coordination, as well as quality assurance. And Kai will help us to understand this better in a comparative perspective. And well, on these words, I'd like to give you the floor, Kai. Thank you.
Thank you, Giovanni, and thank you for this invitation. I feel flattered, and I was thinking that this is quite a challenge here to speak in front of you, because well, there are both experts in long-term care, and there are prestigious students from so many different countries that it is difficult to find a common denominator where to start. What will be the breadth and depth of this short presentation? We could, of course, do at least a 3-day workshop on these topics, but I tried to put something together so that we at the end of this session will have a kind of a shared understanding what we understand by long-term care and how this links to your topics of aging in place and aging in general, and what are the key challenges. And I apologize here, it is mainly on Europe, and I see that this is actually a very privileged situation that we have in Europe when it comes to long-term care. Even here we are talking still about emerging long-term care systems, but if we only pass some other frontiers, we see that in many countries the term long-term care is perhaps not even known. And so bear with me, and I'm actually hoping to learn something also from you, not today perhaps, but across this whole program, how we can understand the development of long-term care in a global perspective, starting from the difficulties that we have already in Europe to compare systems. My background has already been presented, so I would like to start with the definitions and terminology, then talk about the challenges and solutions in setting up long-term care systems in Europe and beyond, hopefully, and give you also some ideas about what innovation, because this is also an important part of this program, what innovation might mean in the context of long-term care. Starting with definitions, so I just took those that are currently used in an international context, be it here by the European Union and the Social Policy Committee. So here there is, let's say, the basics. What is long-term care? It is about support for people who are dependent over a long period of time. And it also embraces all, so people at all ages, and I think this is our common approach to aging, that aging starts with birth and is not only about older people. So then if we look at the OECD definition, here we see that, of course, it's again the prolonged period of time. But here, what is brought into the game is who is providing this care, and this is to a large degree. If we look at it globally, I think so. There are societies where almost 100% is performed by family friends, and then perhaps more and more percentage points of caregivers, often lower skilled, but increasingly also skilled for providing care in long-term care. And then there is a WHO definition that brings into the game basic rights, fundamental freedoms, and human dignity. And it looks at systems that enable older people to receive the care and support they need. So this is also an important progress, I would say. Of course, if you look at long-term care from the health perspective, the first thing that comes to your mind is that here often people end up in the healthcare system and in the institutions of the healthcare systems wrongly, or find a wrong place in, for example, a hospital. I don't know whether you have ever experienced a person with dementia as a patient in a hospital. So these are probably not the right places. And so here WHO underlines that this is, of course, one thing that is also regarding resources. And in terms of resources, this definition also shows that often the fact that you have somebody with long-term care needs in the family might create catastrophic expenditures on the individual level. On top of that, mainly on women, who are usually the main caregivers. So here it is also about enabling or giving women the choice whether to care for somebody in the family or not, or to continue, for example, employment in the labor market. So these are all factors that are experienced by users or by persons in need of long-term care. Usually, and when I started to do research and in this area more than 30 years ago, the term long-term care was often not understood by anybody. There was and we have also, in the international context, we need to also underline that in the English-speaking countries, it is often the term social care is used for long-term care. That's where it comes from, or actually it comes from, as I said, from informal carers. Then what came up where was residential care in the social care system, or people end up in the healthcare system or address or go to hospitals, for example, or other providers of healthcare that are actually not really appropriate, because the healthcare system is there, and we have seen this also during the pandemic. It always has problems if it cannot cure people. So if there is no cure, then healthcare systems have a problem. And here we have to do with chronic diseases, people with long-term care needs that cannot be cured anymore, but need to be cared for, and therefore something in between these systems. So there is this health and social care divide, where the users are thrown from one system to the other. One is relatively well developed and has actually had made huge progress, the healthcare system over thousands of years. While on the other hand, we have an underfunded, underdeveloped system. And now, so that's the question: what do we want? For example, in particular in countries where there is nothing like a long-term care system, do we want to coordinate, integrate the social and the healthcare system, or is there something, and this is what we experienced over the past 20 years or more, that there is something emerging, something in between, an own system with an own identity, own policies, own structures, and so on, that are still, in between the health and social care system, and that take into account also the formal informal care divide. What is clear compared to, well, also in healthcare, of course, we need the support of families in terms of transportation or whatever, but and we have many countries where families are also still providing the food or other things in hospitals. But in general, what is a basic characteristic of long-term care is that here the amount of informal care input is very high. So actually, this lower part should cover at least 80% of the whole picture, and that there is this formal informal interface that needs to be tackled if we talk about a long-term care system. No long-term care system will ever be able to get rid of or to professionalize completely this area. There will always be some part of informal. So what we need, because then there are also some idiosyncrasies in this system still around. Volunteers play an important role, and perhaps we will hear about later or discuss this also. Live-in carers, often migrant live-in carers, that are currently holding the system together in many. So so it has become clear what we need is something in between. Call it an integrated long-term care system, or as in England, the social care system. But we need something that responds to actually the outstanding success of the health system, and of the increasing longevity due to this success. But our living longer is often linked to living longer with long-term care needs, and therefore informal carers are more and more under pressure. Informal care today is something completely different compared to informal care 50 years ago, just because of the increasing increasing number or share, and the increasing demand in terms of dementia care, for example, or multiple diseases that have to be tackled with, but to be tackled in terms of care that is necessary to yeah, to keep people alive with a certain quality of life, even with care needs. And on top of that, we have also seen across, at least across Europe, but I see also more and more across the world, that long-term care is seen as a social risk. Also, I think also here WHO has an important role. For many years. It has not been acknowledged, but for over 10 years now, long-term care is an important part of the WHO discourse also. So here, all countries are confronted with the challenge of overcoming fragmentation. So, well, in a larger EU project, we outlined some of the elements that would need to be developed, and we looked at examples where this has already been addressed in terms of developing an own identity of long-term care, own organizational structures that go beyond the traditional care home, and related quality management and the management of pathways and processes that are linked to exactly these processes at the interfaces between health and social care and between formal and informal care. And you need specific resources for this and specific policies. And we now have, there are also already now some ministries, for example, in Austria, we have a ministry that carries the name long-term care in its name. So it's a ministry responsible for care. And this wouldn't have been possible 30 years ago. Yeah, so any questions until here? Is this appealing, or do you see any link to your work in this program? Where have you come across long-term care challenges? Yeah. Yeah, please.
Thank you so much for this interesting presentation for now. That you're what's the situation right now? Because like all of the things that I've been reading, the long-term care should be like institutionalized and like governed by the government, like institutions or anything. So about the informal care that you mentioned, that's like increasingly been on the table when we're talking about the long-term care in the European context. So I'd like to, if you could like elaborate more on this. Is there like policies for this approach with the long-term care in the European context, or is like a more of a emerging trend right now, or would be great, right?
Yeah. Yeah, as I said, so for
sorry, Kate. There is is it a connected question or is it a different question?
Yeah.
Sorry.
Yeah. At the European level, what is happening? There is more and more discussion about it, also in the context of the European Pillar of Social Rights, but there it's all more about formal access to formal care, which is of course one thing that is also supporting informal carers. But on the other hand, what has been progress is the organization of informal carers. which is very difficult, of course, because people are caring and obviously have no time for political discussions or whatever. But nevertheless, there has been progress. There are now almost in all member states national organizations that are dealing with or representing informal carers, and there is Eurocarers, an umbrella organization at European level that is pressing for supporting informal carers, and also on the national levels we see more and more approaches, but still very small steps. And often it is also compound because you have, of course, at the same time you have childcare, you have carers at working age, and you have carers, pensioners, so spouses. I come to that, and so there are also very different needs and different groups that have to be organized.
Yeah. Thank you, Kai. My three different areas for research questions that come to mind when thinking about long-term care.
Yeah.
The first one is mostly about the size of the demand here. If you have statistics or other research concerning the percentage of older people demanding or requiring long-term care in Europe, and about trends on that. How is that expected to rise over time? The other question is more about the governance of long-term care systems and the role of state actors versus non-state actors, and co-responsibility within that governance.
Yeah. And the third?
The third one, maybe the most difficult one, is about the evidence on the economic benefits of long-term care investment. If we have advanced studies on that, the European context, other than the social benefits. More evidence, economic evidence that can help us convince politicians on the importance of this.
Yeah, we come to that. Well, actually, why, for example, EU is dealing with care. One of the reasons is because one of the key objectives of the EU is to bring women into the labor market, to increase so that there is a clear indicator participation of women in the labor market. Care is one of the hindering factors, and therefore it is also in the interest of the economy to support especially women to choose between employment and regarding and often, yes, it's true, often long-term care is only seen as an expenditure, but actually what many studies show, it is it's actually value added. In particular, if you take into account that by installing services, you enable women to participate in the labor market. If you take all this, then of course care is actually contributing to the economy, but some economists see it a bit different because you could use money for other things. But anyway, but here we have we can discuss this. And I come to the other questions. One more.
Any other question now? Yeah.
So in Slovenia, for example, we are now making these transitions of informal carers to have a status of employment and salary.
I think is quite challenging, but advanced thinking. I don't know where other European countries are in this. Maybe you can, if you have some information, which countries provide this, and which are more behind.
Yeah. So actually, we will see. Well, usually the Scandinavian, the Nordic countries are those that are, ahead in the development of long-term care systems, because there was a clear, a clear political will to professionalize care and use this sector also to have women participate in the labor market. This started already in the 1950s. So there was a clear policy towards this. And this has not yet been in all countries. So the question whether you more or less, and also in the Nordic countries, there is a possibility that you become employed as a kind of home helper, as an informal carer, but it is not used that much. But now we have this also now in Austria in one region, and some other countries are also trying to pay the informal carer for the care. Usually it was done by allowances, but now it is really employment. And this model is of course one additional one. Actually, it is not so successful. Of course, there is a small group of persons that might use this, but the problem is with long-term care, you never know how long this takes. So it is longer, but it can be 1 year, it can be 10 years. And if, for example, you quit your job and say, okay, this is now my new job at 50, for example, and the person you are caring for is dying after a year, then what are you doing then? Are you then going back to your old job? Or when one good thing about this is, nevertheless, you get also some training, and you could then also care for other people, and so become kind of a professional carer or home helper, or add additional modules of training, and become a long-term care worker. This it would be, of course, one possibility.
Yes. Okay. Thank you very much. I also really enjoyed the different definitions that you gave, because it felt like the OECD one talked about who was involved, and the World Health Organization talked about why it matters. I'm interested in how much discussion there is about where this should take place, and the variations between different countries, given that this conference and our project is very much about aging in place, and you can interpret that in many ways, but predominantly about staying in the same kind of home or in the same kind of community for as long as is appropriate. So how many kind of conversations are there about whether long-term care should actually be institutional, whether it should be at home? Thank you.
There we could really talk, but I'll come to that. Well, there is a general drive towards aging in place, and also because most of the people want to stay at home as long as possible, even with long care needs. And we'll come to that. The question is really, so who decides? What are the possibilities? And this has to do with policies, with individual expectations and preferences, and, for example, with the availability of informal carers. And if this is reduced to family in the strict sense, then with aging in place, you might get problems. So now we have, for example, movements like dementia-friendly cities or age-friendly environments and so on. So there is a lot of discussion going on about aging in general, aging in place, and aging with care needs then in place. Just to give you a 40 years ago in Netherlands, I think there were 12% of persons over 65 were in institutions. Do you know how many there are? What's the share on average today? 4? 5? Who wants more? Yes. So now it is in general across Europe. It's between 4 and 5%. But in Italy, for example, it's not even 2. In the Netherlands nowadays, we are down at 7 or so. It depends also what you how to define care homes and so on. But so this just shows you the development and also the thinking of in this area. So there has been change, also due to sheer costs, because both in Sweden was a bit the same situation as in the Netherlands. It was seen that okay, this cannot go. We cannot afford this amount of persons in institutions. So this was also of course an economic reaction. Hang on, because otherwise the others don't hear you.
In the Netherlands, the situation was that after World War II, a lot of these the more residential homes were being built.
Yeah.
Where people lived.
Yeah.
Well, they had a communal room, etc. But
yeah.
there was hardly any care provided.
Yeah.
It was needed.
Yeah. This
they
was
entered
still
when they were
sure.
60, 65. They
Yeah.
wanted. It was a housing problem too.
Yeah.
So this is what happened. So we had many of those institutions. But nowadays, hardly any of them exist anymore, but we still have nursing homes. And
yes.
there's a lot of care, long-term care needed. So
right.
It's almost residential homes.
These were still the old traditional residential homes that were a reaction to housing problems. And people were living there also long, 10 years or so. Today we have nursing homes where the average length of stay is 2.5, 3 years or so, and nice. not even. And they're really nursing homes, or even I would call them hospices in many cases.
The thing is, there's a housing problem now, again. So there's a lot of discussion about it. Should we reinvent them?
Yeah. Yeah. So why is this also becoming a more pressing problem? It's also because, of course, the longevity we have gained in terms of life years. What was it? I think 6 years over the past 20 years. And this graph just shows you, well, of course, aging as such does not mean that you will become will need long-term care. But the older you get, the probability that you need care will rise. Of course, prevention becomes an issue, and but you also have a lot of inequalities here. This is not in this table, but graph you see. But in general, this really changes with income and education, and also, of course, what and how you passed your working career. Yeah, it was already mentioned. So it's not only long-term care is not only an expenditure, it is also an area of, or actually has been for many years, the area for employment growth in many countries. But this also shows you the differences of, well, here it's health and social work activities. So you see in some countries, it is from a higher level, it is reducing, while in other countries, it is only just starting. And still in all countries, we are facing lack of care staff. And especially, I would say, a lack of appropriate care staff in long-term care, because there is no long-term care worker. What we have is, education in the health system or in the social care system. And very rarely you find job profiles that are combining these two. And this is actually what we would need in long-term care. And therefore it might still take some time. We have such a job profile in Austria, introduced by law in 2005. The first came on the labor market in 2012, but as they were so, not enough, they are still not in the usual staffing structures and so on. So it takes many years until you really establish a new job profile in this area. Then there was a question about prevalence of informal carers, which is very difficult to really find out, because it is, of course, a subjective view, especially, well, here, this is from Share Survey, where the question is, do you spend any time looking after or giving help to family? So it's very broad. And then what does it mean? Is it 1 hour per week, per day, or whatever? Yeah. So we can discuss this, and therefore you see also very different patterns in different countries. In general, you see that there is more, because this is, so the Share is a survey for people 50 plus. So this is the population 50 plus being asked, and it shows that in many countries, of course, an increase between here from 2004, first wave, to here 2020. For example, in Italy, why it's so low, I don't know. And also in Greece, this is because actually these are the countries where the family is providing more care. So yeah, I think there is a problem with Share. Do you have any hunch?
May I react? But I see there is a question. Sorry, we have people online.
Forgetting about our colleagues online. Presumably, a large proportion of this is older persons looking after children, not just older people looking after older people. The question doesn't seem to differentiate.
Yeah.
In which case, in Italy,
but still in Italy.
In it, maybe this is so pizza.
What's your hunch?
Still, I think that the lack of alternatives to grandparents in Italy would keep it high, despite the lack of children. But I think the issue, which is not here, it's the intensity of care. And you talked about perception. What does it mean to provide support to someone? So if you don't even see it, that you are supporting someone by going every day there, just have a chat and doing some shopping, you don't consider it as
informal.
They don't consider
They don't
themselves.
see it.
It's
So if you
normal,
ask
it's
people,
family.
they say, well, that's not care. That's part of family activity.
Yeah.
So that you don't see that. So if you see Denmark and Italy very close to each other, you see much higher in Denmark, and you will never see Denmark as a family society. But
Yeah. No, but so Danes obviously, if they visit their mother, father, then they see this as care. While in Italy or Greece, it is part of daily life. So why should I bother? So this is so yeah. So it is very difficult in surveys and to find out. We just did also a study in a region in Austria. So the range is really large. Where does it start that you are an informal carer, and where? So example here, is it spousal care or is it intergenerational care? So here in this Italy is a bit higher. So yeah, in sometimes these surveys are also problematic. Yeah. But perhaps here it comes across a bit better. Yeah? So I don't know why Luxembourg is so high, but all the others here you would expect that intergenerational care is much more important in Italy. But for example, why not in Hungary? So there are some puzzles. Yeah, then this is something actually I stole from Giovanni, who worked already many years on this. Because especially, well, in Italy, but also Austria, are countries that are, well, the long-term care systems are held up actually, or yeah, are depending very much on this phenomenon of live-in migrant carers that come from countries always, always further away. For example, in Austria, it started with women from Slovak and Czech republics. Now, live-in carers are coming also from Romania and Bulgaria. In Italy, they're also coming from Ukraine and other countries, and it started with Albania, Romania. So this is really a phenomenon. If we talk about aging in place, what does this mean? If you have carers coming from abroad and ever further abroad to care for somebody in his or her own home. So here, this is really an area where we need to develop long-term care systems to at least to either integrate this workforce into the normal workforce, and in particular to think about what does this do to the source countries. So if I don't know, 800,000 Romanians are caring for Italians in Italy, what does this do to the Romanian families and so on, and also to the Romanian long-term care system that should also be developed. Romania is, yeah, part of the EU and so on, and other countries too. So this, I think, is yeah, how could you call it, a group or something that keeps problems away that would so yeah, we reckon, for example, in Austria we save 10 to 20,000 places in care homes due to this. In Italy I wouldn't dare, but I think that, yeah, many systems, not only the long-term care system, but many systems would break down if this would not be there. Yeah, then there was a question also, so how is this going with the deinstitutionalization and institution, so aging in place and political discourses. There is a huge discourse on deinstitutionalization, also starting from persons with disabilities, children, but also older persons. And here we see that, as I mentioned, yeah, on the one hand, the facilities are changing. So they are not the old age homes anymore. There are nursing homes, there are hospices, and they might be needed in long-term care for older persons at some point. But there are radicals also saying, well, actually, no, no institution should be allowed. Should close all institutions also in long-term care for older people. And yeah, I'm a bit in between. But you see in Italy, if there are no institutions existing, and Italy, probably also due to the anti-psychiatry movement, was always anti-institutionalization, and therefore also institutions in care for older persons were not really developed. Yeah, but there are very different approaches in the different countries. But of course, you can have an institution can be 500 places, or it can be 20 places, and then it's already a different thing. It can be specializing on persons with dementia, and then you can discuss: is this the real way, or do you want dementia villages like in the Netherlands and in some other countries? So is this then an institution, the village, or is the institution only the single residence? So this is an important discussion that you will come across and that you have to address. I think if you discuss about aging in place, then this is, of course, a most important thing. What we see, well, we see a bit if we look at these numbers. We see some convergence. So places are, yeah, but take care, because 1,000 inhabitants in 2000 were aged 65 plus in 2000 were less than in 2020. So it's so even if the share is being reduced, this does not mean that in terms of numbers they are reduced. So this is all very critical if you compare these data across countries, because of course there are different definitions of a care home in one country, and of course and the same with informal care. Do I define myself as informal carer, or would there be objective measures to define what is an informal carer, and at what point are you becoming an informal carer? Yeah, what would be quantitative data that you would like to see or address? Yeah. Do you see? Because there was something in chat.
Thank you. My name is Lisbeth Donder from the Free University of Brussels. And in Belgium, and particularly in Flanders, we see past 10 years an increasing shift in commercial residential care facilities. 10 years ago, there were like 10%. This moment, we're at 20, 25, and some cover-up public residentials which actually are commercial behind them. And it's this increasing trend of not only commercialization, but financialization at the end, actually, which is really changing in Flanders at least. And I was wondering if there are numbers across Europe of the shifts in commercial financialization.
Yes, this is one of my favorite areas of research actually, but I didn't because it's really complex. But as these long-term care systems were starting to emerge during an area of neoliberal and market-oriented governance approaches, I'll come to that. One issue was, of course, who provides and who pays, and the general idea, less state, more market, and so on, had a huge imprint on this development of long-term care systems across Europe. Well, but you see it mainly. So let's say the Germany, UK, where especially in the 90s there was movement and there was the expansion, but the thing was that the state, so for in Germany there was the introduction of long-term care insurance, as you might know, so there was a lot of money in the system suddenly, but at the same time the state didn't want to be a provider of services anymore, and the same happened then in Belgium, in the Netherlands, yeah, you name it. Also in Sweden, a bit less, bit more regulated, but still, the question is, then, or what happened then was that huge, hedge funds and so on took over because they were able to invest while the state, shied away from investing. But of course, as it was hedge fund, it was investment, so they wanted something back. And actually, they found that this area of care for, of long-term care is actually a great area because you have, so there is demand and there is not enough supply. There is, in any case, you're sure to get your money because the state pays for people in care homes. So all you have to do is to keep your occupancy rate high. You will get your money, and then and as a hedge fund, I just ask you 6% or something. So it's safe income. And now I think there's only in the Netherlands I saw this, but some smaller countries, but nobody is really questioning that via public money you're doing private, you're gaining private, from private investments you get private profits. But this is actually mostly public money because in residential care, you have, of course, also high out-of-pocket payments, but most of it is public money. So, yeah. But this is a, yeah. How much time do we still have?
Thank you for the amazing presentation so far. I am Ana Fatima, and I'm studying in Switzerland, probably actually as well. So I had this question that how quality and accessibility of care could affect the choice of people to opt for long-term care, and if it is affecting the figures that we have seen so far. Also, I had this question about equity, if putting long-term care into social care is going to affect the equity and accessibility in general, or should we think about it as like a healthcare system responsibility to improve equity across the London.
Yeah.
Thank you.
Yeah, well, of course, equity and inequalities are a huge topic here regarding gender, income, you name it, education. We know that, mainly women are providing care, but also using care. So this is one thing, and that there are huge regional differences in access quality. But so if you take, and I think Stefania will then mainly discuss the issues of universalist access in healthcare. So you also want this, of course, in long-term care, like universalist systems that exist in the Nordic countries. But and I come to this now. The challenge is, how do you define long-term care needs, and who needs what? We're getting there. Yeah, perhaps I just actually it's the next because one thing you might have asked is, of course, what we need is to know who is spending how much money on this area. And also there, again, we have huge difficulties to define this across countries. Is this, so here you see the share of public expenditure on long-term care, but of course there's also then the private component of this, and therefore, you cannot, what are you really comparing here? And the Netherlands, for example, are very high because they have a defined area of, and now it's even called the Long-Term Care Act. But before it was the RBBZ or something, where there were a number of expenditures in it that in other systems are in healthcare anyway. So so you always take these comparisons with caution. Yeah? This is just for the quantitative part. But now coming to this question, so what do you really need to discuss if we talk about long-term care systems? And one key question is the definition and assessment of long-term care needs. Then the role of state funding and private contributions, the balance between benefits in kind and benefits in cash. Then we also had this residential care and care in the community. So is what is your approach there? What should policies do there? You should enhance prevention and person-centered care delivery. So this is not so much about prevention in terms of giving up smoking or things like that, but it's more about prevention in the organizational thing. Yeah? So how to guide people through the system, for example. And then you have this huge question about the role of state, the market, households, and what we call third sector, so communities and cooperatives, for example. So what's the problem in defining and assessing long-term care needs? Of course, we have heard already in the definitions also, it has something to do with the activities of daily living and the instrumental activities of daily living. But still, it makes a difference. So, for example, you are in a wheelchair and can move around normally, but unfortunately, you're living in a building, the 4th floor, without a lift. Then you have, of course, other care needs than somebody with you. Yeah? So it is the environment that takes that is important. Then you have also systems where they say, well, actually, or now in Hungary, it was even put in the the Constitution. So actually for long-term care, the family is in charge. And so if there is some family member, you cannot have care needs that are tackled by the public system because you have a family member. You can also, so this is what I call to define away long-term care needs. You can either expand this or you can reduce it and say, well, actually, or you have many systems where it depends. For example, in Austria, it is now 60. So in order to get the long-term care allowance, you need 65 hours of care needs per week. Yeah, out of these ADLs and IADLs all put together, you're being assessed by a nurse or a doctor, and then, yeah, but 65 hours could also be, well, actually, some years ago it was increased to 65. It started at 50, I think, 30 years ago. So now, yeah, so it's arbitrary. If you have only 64 hours, sorry, you don't get anything. So these are the challenges here. So if you define a state, okay, if there is informal care, is an informal carer, we don't care, then this is one way. But in the assessment process, usually you should also, so if your aim is to expand or to increase or to improve access, then you should not define the needs away, but try to find ways of defining the needs and defining also the delivery of services together with the environment of the person in need of care. So this also means something like case and care management. This means active, proactive counseling. Many people are just overwhelmed from one day to the other. Somebody in the family is in need of care. And then you are obviously not prepared for that. But you should organize services. You should know what kind of services are, what are the alternatives. And therefore, you would need support there for informal carers, but also for the person. This is a crucial area, assessing needs and based on that plan the care you want to do. We developed one model in Bolzano et Adige in an autonomous region in Italy, where a team, so two persons, one from healthcare and one from social care, are getting involved in a dialogue with the person in need and his or her informal carers, and then do also the care planning and information together with. So there are less than a gate, because this is also the one moment where the person in need of care is faced with the system. Yeah, because they are in their private, they are in their living environment. Now the system is supporting them. And here you need support, you need information, and this is therefore a crucial moment. Also in England, you have a right as a carer to get your needs assessed, and yeah, but often, as far as I know, I don't know, is there anybody from the UK? The problem is often then, okay, then your needs are assessed, but nothing follows. Then also, this is not so good, I would say. But at least there is a, let's say, an awareness that the carers are experts in care, in experience, in any case, and then, yeah, but you would need more choice afterwards. Another thing is to move away. So as I said, long-term care comes from the rationale of social assistance, of social care. And there, means testing is usual, and out-of-pocket payments. While we see now more and more, especially also in the universalist systems in Nordic countries, that this is moving away. So it's more about needs testing, as I just heard, and not about means testing. So yeah, the general approach would be, okay, well, if you the care as such should not be yeah, should be the right to care, and this should not depend on your means, in order also to tackle inequalities and wrong incentives. But still, you have, as you see from this figure, also you have in many systems. So we all the gaps are filled by informal care. So the gap of who is covered. So those who are not covered are covered by informal care, hopefully, or not at all. We have also people that are not covered. So then you have the range of services you would need. But if they are not existing, informal carers step in. And the same with costs. And also there, we have many countries where not only the person in need of care has to contribute with wealth and income, but also the family members. And so this was waived, for example, in Austria some years ago. And it was interesting to see, because people then said, oh, now nobody has to responsibility anymore. So people will they will rush into care homes. Obviously, this was not the case. Nobody really wants to go to care home. Yeah, there were some people, of course, waiting before this regulation was started. So they didn't go, they didn't move to a care home before. But then once it was, and so there was a gap for 1 year actually. But for the rest, this is not an incentive. So if it's paid, of course, you could see it as a wrong incentive to move to a care home rather than use services, because services are still paid. But in any case, you need resources, you need some kind of funding for a long-term care system, whether it's a social long-term care insurance, whether you build in a choice between benefits in cash and in kind, or a possibility to mix both like in Germany, or whether you have in Austria the tax-funded cash benefit care allowance, or you have universal access, as in the Nordic countries, that are service-based. So there you don't get money, as we have seen in Italy and Austria. This the cash benefit might have triggered, or has certainly contributed to this employment of live-in migrant carers, because there was money in the system. And there was money in the family. So in the Nordic countries, this phenomenon does not exist because there are services with other problems. Yeah, I skip this. I think there is, of course, pros and cons for social insurance funding, for tax funding, or for a universal service-based access. Yeah, and countries are dealing with this. For example, in the Netherlands, in Sweden, this the fact that actually, well, the services were kind of patriarchic, because yeah, so there were only the services, and you had no choice as a user, and especially persons with disabilities. then said at some point, well, actually, we want more choice. We want personal assistance and not a service that tells me when I have to get up. So this type of discussion has also must be taken into account. Self-determination. How can I support the person in need of care and or a person with a disability to decide for him or herself? Yeah, we discussed this already, the deinstitutionalization versus community and community-based care, because often this is also not well understood. Deinstitutionalization must not mean you have no residential care at all, but you might have different types. You might have residential care that is open to the community, that is embedded in the community. And I guess Stefania will also talk about this more. And to get this long-term care out of the familialistic lens only. I think this is important, and especially if you are working on aging in place, how to get this out of the family. We have many societies, especially in Eastern Europe, it's still so that families often hide persons with disabilities or in need of care in their homes. They don't want to go out. They don't want to have support in the community. And this is something that might or should change, obviously, over the next time. But therefore, you need also community structures that are helping in this regard, changing or raising awareness and so on. Prevention and reablement is another thing what we need in the development of long-term care system, at this coordination at the interfaces between health and social care. And here is a good example from Denmark, but there are also other countries where this has, especially those where services have already been developed, because you need, of course, a service infrastructure in the community in order to communicate with the health system. And here it was shown that, well, what is crucial is also at the beginning of long-term care, persons are discharged from hospital with long-term care needs. And then sometimes there are systems that are bringing you to rehabilitation or rehabilitation centers. And here the idea was actually to say, well, no, this person has now long-term care needs, wants to stay at home, and needs training how to live in his or her environment with these care needs. And therefore, we provide a team, an interprofessional team, that really invests for 2 months or so and trains the person to live in her environment. And then the person will need less or no services at all, because this training has taken place. So here, this is a good example for this working at the interfaces between acute care and primary care, and then the community. This is now a discourse that has been going on for 20, 30 years. This coordination, integrated care within health, but especially also at this health and social care interface. How can you coordinate this discharge? Management has been introduced in the hospital, but often this is to reduce number of bed days in hospitals, but not really to develop then life in the community and life in place. Also this joint and partnership working across social and healthcare, we are working on it. Yeah. And in any case, what is needed is, as I said, what we need is also actually a job profile for a long-term care worker. And there is something like the community community nursing, which is a bit in this direction because you have the social component in it. And actually, this what happened in the Netherlands, where there is such a education of community nurses. They then came to the practice and saw that this was completely different from what they had learned. Because there it was about, well, they were nurses and in the home, they went there 10 minutes to change diapers or to change something, to give medicine and so on, and move on to the next without any holistic approach. So actually there was then one group of community nurses that said, well, actually we want to organize this differently in autonomous teams that are working in the neighborhood. We put the client at the center, use all the local resources that are there, cooperate with primary care and other stakeholders in the community. And then once we have enough clients, then we create another team in the next neighborhood. This is how they grew from one team to now more than thousands or so across the Netherlands, and they also introduced a new way of working together in these small teams with very autonomous approaches, and the organization then grew, but with the help of software, they could keep the back office small, and of course, but this is taking place in a system where there is funding. This is also important to say. Yeah? So there, this type of work, and they were also able to show that they actually needed less hours than were defined by the assessment teams that are existing in the Netherlands. So they have also been criticized for this, but actually they became several times employers of the year and so on. So I think this is one of the most innovative approaches that we have seen in long-term care over the past years, and that can still be improved and further developed. But I think the approach is really also, if you are working on aging in place, this is one important tool or instrument or approach that you should consider. Yeah, to finish, just a few words to shaping what we have in long-term care, as in all social areas, social welfare areas. We have here a dynamic between contributions from households, families, the state, the market, and then depending on the countries, some have a long tradition of the third sector, of cooperatives, of associations, of different organizations that are providing services, for example. So not only market and state, but also third sector organizations that are playing a role here. And here it is about setting up a market regulation that is equal for all, that provides also equal access to the different providers, or not, or to say, well, actually, I don't want to have organizations in long-term care that are making profit from public money. This could be, but I think we are too far now. How to stop this? But what we can do is really regulate the market and make it a level playing field for all, state, third sector, and market, and bring in also the informal care in this welfare mix. Yeah, I hope this was a bit an overview, but what just to finish with is where do we want to go in long-term care? Also regarding this, for example, this question, who are the players? Who should provide the care? And how can we move? What we now have is a mix of paternalistic welfare state systems, where, according to the countries, there were different types of new public management implementation systems, especially used, and the long-term care. This is why I'm so fascinated from the long-term care system, because this was especially during this phase that you could see what is this new public management do. Does it do to the system, to the people, and to the governance systems here? And we see still elements, of course, of the paternalistic system in many countries. We see parts of this new public management where, of course, it is increasing choice. You see the user as a customer. But if you have somebody with dementia, where is the choice? Where is the support to choose, for example, at least? Or and what is the what is the competition bringing to the user? Of course, this sounds all very nice. If you are not a user, you're not a patient, you are a consumer, or you have rights, and you have a consumer organization that is supporting you. But this is problematic in several areas of long-term care and also in health, I would say. So how do we get into this ecosystem where we create values in small networks, where we hopefully will have outcome financing at some point, where it's not about individual services that are provided, where service providers have the incentive to produce more services rather than the right services, probably. And where we really center our services on the person, based also on continuous improvement in terms of quality assurance. Here, I hope that there will not only be, of course, we need minimum standards, but we need some standards, thinking out of the box and thinking towards the future that that goes beyond minimum standards. Yeah, I stop here and hope to share something.
Thank you, Kai. We still have some minutes left for questions. I see already one over there. Thank you. And another one over here, and one there, and one there. 4.
Hi, I'm Lou. I'm one of the doctoral researchers. I'm based in Brussels, but I'm actually from Vienna, so very interesting to hear this talk and many insights about Austria as well. So my research is on housing and specifically community-based housing for older adults. So I think this could be part of this ecosystem value creation model that you presented here. I was wondering what you think is the role of the housing system and specifically the social housing system in bridging these gaps between social care system and the healthcare system that you presented here, yes? And just to give an example, I was talking to a community-based housing group, and they were actually thinking of providing care and focusing on older people in the housing and community they wanted to provide. But then they decided against it because they said it's so complicated already to form this community-based housing group. There's so many regulations coming from housing, and integrating the regulations coming from the healthcare system and providing care would be too complicated. So they decided against it, and now they're not focused on older people or aging or providing care at all. So I think there's a big problem there in bridging these two. And also probably in academia as well. And my research is coming from the housing study, so I actually haven't read a lot about long-term care, though it's so related and the discussions are quite similar. So yeah.
Yeah, I'm hoping in you that you integrate this. It's already crowded, this graph, but actually it needs still many things like housing, like transportation, like AI now, whatever. Yeah. So this is still fluent and dynamic, but I see it, and I see this point. I think in Austria it is still that as soon as you have 5 older people with long-term care needs in one place, or 4 or 5, then you have to comply with the nursing home regulations. So obviously, you won't create a small unit for older person with long-term care needs. So on the other hand, you have things like the 24-hour care or these live-in carers where there is almost no regulation. So yeah, this is really also showing where this systemic development is, and that we are actually really talking about emerging systems, where it is very important to add pieces. Yeah? And housing is of course one, and also crossing these silos. Not only so that so if housing research does not communicate with long-term care research, please go on.
We have another question over there. Michael.
For your very comprehensive, clear presentation. I have 2 questions. One is about your last slide with the future of long-term care policy. What role do you think right space approaches have in this the transformation or the development, future development of the ecosystem for care, for long-term care? That's the first one. And then the second one, it's about specific literature I'm familiar with from the UK social care system. That is, the literature is very critical to the definition of need, eligibility criteria, because these authors say that usually it's very resource limited need definition, right? Like the local governments have an amount of resource allocated for long-term care, then needs are defined subject to that. So in your experience also, this is the case, and how we can transform that. Thank you.
Yeah, how we can transform? Yeah, this is a $100 million question. Yeah, of course. But what we have seen, well, there is some development towards more rights-based approaches. But of course, this defining away needs or defining needs according to the supply, this is what we see everywhere. Yeah? Unless people get organized, and there is, interestingly, because we always say, well, the Netherlands are far ahead and so on, and they, but especially now also in the Netherlands that there are what is this, caring communities that are popping up, And so within a system with some rights, they say, well, actually, yes, but this system doesn't work. We want to take this in our hands and form a kind of bottom-up care. So we build our care homes in the in the small village, for example. Or but that perhaps our Dutch colleagues could elaborate on that. How this is developed. I heard of it several years ago. In between now there was COVID and different other changes in the world. How this is developing and whether you see the future for that.
I would say we complete with the last two questions we had, and then we deserve a coffee break in 5 minutes. So
yes, thank you very much for your very informative presentation. My name is Maria Aerts and I'm from Norway, working at the Oslo Metropolitan University there. In the beginning of your presentation, you mentioned that informal care actually is the backbone for long-term care systems. And also you mentioned 80% should be long-term informal care there. I don't know if this is a sort of ideal, sustainable balance between formal and informal care? Should it be 80-20, or is this an ideal situation, or is it how it is right now? So I was just wondering about this.
No, it's just the empirical, more or less. This is just how it is. Yeah, I don't say it should be like this. In some countries, it's also here, depending on the definition and so on. In some countries, it might be 60-40, or again, depending on how you define needs. But this is not a normative thing, I would say. But it must be clear that in any case, informal care will always play an important role. A complete professionalization probably we don't even want, but we can discuss it. But in any case, the 80% is, as most scholars say at the moment, so on average, this is what is provided by informal carers. But I think you will never be able to really put this in stone. And of course, but this could be part of the public discussion. So how, before defining away the needs, we look at who can do what. Both in the micro, on the micro level, but also on the macro level, to discuss, okay, here we have a social problem that needs public support or societal support, and therefore we define needs for each individual, and then discuss with the resources around, and I come back again to this community nurse idea. So we discuss with the resources around what we could do for Mr. Miller or Mrs. Smith. Should we, can the grocery shop bring something at that point? Or can, I don't know, the pharmacy or the primary care center contribute at which point, and so on. So this kind of discussion should take place both locally and then also at other levels.
Last question.
Is it on? So if we're talking about a long-term system, and I was thinking that what are the quality indicators that will help or support the measurement and the evaluation of the competence and the efficiency of these systems? And on one of the slides, there was a question about how to compare those systems, and I can't help but to think
For example, here in Italy, where it's more of a collectivist society and culture, maybe some policies and some measurements which are applicable here might not be applicable in a different context, such as, for example, some Nordic countries or Sweden or other countries. So my question is, how far are we into taking those cultural and political considerations? But how far are we taking those differences of the context into consideration when talking about these policies?
Yeah. Well, we are talking here about, if we are talking about measures and we are talking about quality of life. We are not talking about quality of care as such, or like in quality of healthcare. Yeah, there you have clear, you can clearly define the indicators. In long-term care, it is more about quality of life in the context where you're living. So it makes a difference. You see this also if you look at surveys about loneliness. Often in Mediterranean countries, older people feel lonelier than in Nordic countries, although they have more contact with people than in Nordic countries, because their expectation is higher. Yeah? And the same goes for care in a certain way. And therefore, it will always have a subjective component in it once you measure quality of life. But you always need to take the context into consideration.
Thank you, Kai. Again,
you.
Thank you all for.
And next time, 3 days.
Next time, 3 days. But now, half an hour for coffee break. We start again at 11:45. Hope we are back punctual here. Thank you. Welcome back for the second presentation of the morning. We are now going to listen to Stefania Linka, who will focus on the need to strengthen the partnership between long-term care and the universal health coverage agenda. Stefania is in the best position to do so, as she is, apart from other roles she holds, technical officer for long-term care at the World Health Organization Regional Office for Europe in Copenhagen. She has an extensive experience on the interface between policy and research, thanks to her long-standing engagement in providing policy advice, technical support, applied research and advocacy efforts to national and international organizations, touching upon several issues like innovation and service design in care systems, discrimination and inequity in access to health and long-term care, and particularly in paying attention to strengthening care delivery for people with complex needs, supporting integrated care models, and improving care access over the lifetimes. So her presentation will address long-term care from a public health approach to healthy aging. And therefore, I will not take more time and give her the floor to explain us what she wants to tell us today. Thank you, Linka.
Thank you, Giovanni, and hello, everyone. It's a pleasure to be here, and I look forward to meeting all of you and to learning a little bit more about the work that you plan to do. I want to start by saying that I think you're very privileged to have gotten the intro to long-term care from Kai. I got a bit nostalgic because most of these things I had learned from Kai many more years ago than I like to remember. And it got me passionate about long-term care. And I still am. So hopefully the effect of the presentation today is that it brings some of you to the side of care. And in the future, we'll work together on this. I think I want to switch a little bit focus. So Kai has done a really good job of setting up the scene. What are some of the challenges? What are the unknowns? Where there is space for research to come in and to fill some of the knowledge gaps around care. And some of you might be starting a PhD program just because you're interested in promoting and advancing knowledge. But I think many of us in the field are more motivated about the impact that this work can have at practical level in people's lives. And if that is the case for you as well, then as you navigate your PhD and your career afterwards, you have to think of ways to bring your research and the findings that you produce closer to practice, to evidence, to policymakers. And I think this, can be very difficult. It can be very easy, but it just doesn't happen naturally. So I want to talk today a little bit about where opportunities might be to collaborate and participate in the research process, and what to me really is the key of good policy, but also good impactful research. And that's an orientation towards partnerships and network building, and trying to do to keep a focus across research, across policy, across practice. So, this doesn't work. I'll do it like this. No. Oh yeah, there we go. These were the things I wanted to talk about today. I'm changing a bit idea, listening to your questions, so maybe we can play it a little bit by ear and focus on the things that are interesting to you. So I want to invite you already now to please raise your hand if there's a question, if there's a comment, if there's an area that you'd like me to pause on and discuss a little bit more in detail, so that we use the time in a way that's interesting and useful for you. Yeah. And Giovanni, please help me if I don't see someone. But very quickly, a little bit of a history trip. So if you noticed in Kai's presentation today, much of the data he presented and many of the studies he was citing went, way back to the early 2000s, 2010s. I tried to map here a little bit, looking back, the profile of long-term care in the social policy agenda at global level, but primarily at European level. And I'm going to focus more on the European space. I hope that's interesting for everyone. We can think a little bit more globally in the discussion, but most of my work is on Europe, and I'll focus on Europe here. So the discussion on long-term care really is not new at all. There's been ongoing research, ongoing debate about it. And even international organizations have been quite active in signposting this issue decades ago as an upcoming emerging issue at European and global level. In 2018, the European Pillar of Social Rights was a really important step forward in the European space. And because questions around rights came up today, I do encourage you to look this up. The European Pillar of Social Rights Principle 18 specifically refers to long-term care. This is a unique situation in the world, a right to care. Now, of course, how much power the European Pillar of Social... Okay, and what can I do?
Is muted.
Should I use one of those microphones? I'm not close enough to this one. Okay, is this better? Okay, excellent. Right, so the European Pillar of Social Rights in 2018 recognizes the right to care. Now, this doesn't add any kind of, there's not much enforcement power that comes with it, but I think it did set a standard, and it sets a precedent that there is such a right of individuals to receive long-term care. In my view, and I wonder if from country experiences, some of you here agree, a really significant step change happened with the pandemic. The pandemic had devastating effects generally in health systems, but the effect it had on older people and on long-term care settings was really disproportionate. So we've seen close to 3 million excess deaths in the European region, and 83% of excess mortality was among older people. You might remember now some horror stories coming out of different European countries about the absolutely tragic situation in nursing homes, in long-term care facilities, but also later, as the pandemic kept unfolding, the really devastating effect it had on informal caregivers, on their mental health, on their well-being, because as the long-term care system came to a halt in some places, the burden of care all of a sudden was placed on families that were facing many restrictions and that could not access support services in the home due to all kinds of restrictions. So for better or worse, the silver lining is that in the aftermath of the pandemic, it became quite evident how significant the gaps and the fractures in long-term care systems were, and how fragmented long-term care was from healthcare systems. Two important policy initiatives at global and European level came in the aftermath of the pandemic, and I'm going to talk a little bit about them. One is the UN Decade of Healthy Aging that I understand you've heard a little bit about, so I won't pause too much about it. And the other one is the European Care Strategy that was launched in 2022. The European Care Strategy, again, stands out as a uniquely ambitious initiative, I think, in the global space. And we can talk a little bit about the promise it holds, the optimism that comes with it, but also some of the limitations and where there is scope to help this agenda along. But I want to maybe pause a little bit. Kai hinted at it, but didn't quite address one of the really challenging aspects in long-term care is the governance of long-term care. What is the fact is the responsibilities for financing, organizing, and planning care are held at national or at regional level, in some places even local level. This leads to all kinds of problems. We are in Italy, where effectively we have as many long-term care systems as you have regions. This is also the situation in Spain. This is also the situation in Germany. This is also the situation in Belgium. And this comes with all kinds of complexities at policy levels, with all kinds of equity issues, but it also makes it that much more difficult to promote a unitary, cohesive agenda and to even get consensus on all the definitions that Kai was talking about. So when Kai asked, what would you want to see to facilitate comparison between long-term care systems and what kind of quantitative data would you need? We first need definitions. We have not yet been able to agree on what it is we really want to measure. And it's fine that this is an ongoing negotiating process. I think the definition of long-term care is evolving and expanding for the better. I will try to convince you today, but it does come with the drawback that as long as you don't know what you're talking about, it's very difficult to measure. It's very difficult to measure progress. It's very difficult to measure impact, which we're constantly asked to do. So the point I'm trying to make is that these responsibilities are really held at national, regional, local level. We do not have international instruments that really allow international organizations to push for certain standards in long-term care delivery. There is an implicit, and there's been a discussion around this evolving around the care of people with dementia, but long-term care more broadly, around how an implicit right to long-term care can be derived from the right to health. Equally, if you're familiar with some of the literature and research in the field of disability, you will know about the Convention of Rights of People with Disability that doesn't place any age limitations. So one can, and people have argued, that the Convention of Rights for people with disabilities is in fact setting up a right to care for all people. But in the international policy arena, it hasn't quite worked that way. We don't have a convention on the rights of older people. It's still being discussed. We're still trying to push this through. But in the meanwhile, the role of international organization in this space really is one of convening, of promoting collaborations, of trying to advocate for a certain policy agenda and trying to build consensus between countries. So we are tasked with creating a platform where all these perspectives and different national stakeholders from different regions can come together and decide on what are the joint policy priorities and what are the standards that we want to enforce. On top of that, and especially at the level of WHO that I work on in the regional office rather than the global headquarters level, our mandate is not so much focused on development of guidelines, of policy directions, and on international diplomacy, as it is focused on direct technical support to countries. So we're one step closer to working with governments, working with care professionals in the field, and trying to make these high-level visions, these international policy documents, come as close as possible to reality on the ground. Another important function we have is to promote knowledge exchange, participatory design and policy making, and to bring evidence to policy. And this, I hope, is already making you think of what your role in the whole policy process can be. Finally, we can monitor progress for countries, but only under specific mandates. So the UN Decade offers such a mandate to monitor progress on a series of indicators. Difficulty then becomes, what are the indicators? Can we actually measure them? Are they the right ones or not? But at the very least, it's a step forward. So what is the Decade of Healthy Aging? It is a global collaboration. And again, collaborations should say to everyone here, there are no strong mandates. It is a voluntary collaboration of stakeholders around the world. It's aligned with the last 10 years of the Sustainable Development Goals, and it really focuses on older people. It's a cross-UN collaboration led by WHO. Alana would have talked to you about this, I think. I'm going to focus a little bit on the long-term care aspect because the decade has 4 action areas. One of them is long-term care. What the decade says on long-term care, the vision it sets up is that every country should, we cannot push this, but we hope, we encourage every country to meet the needs of older people for long-term care. And just highlighting a few aspects here, helps them with daily living and personal care. So think back of the way Kai referred to how do we measure needs. This is, in a sense, implicitly, a way of defining what we might think when we say need. So the help with daily living and personal care, but that enables them to maintain relationships. Social participation is increasingly recognized as a key aspect of need for care. This was not the case when I started working in the field. It was all about ADLs and IADLs. Now we're talking about connectedness, social participation, combating loneliness. It's a big and important step forward, I think. A right to age in a place that is right for them. So first and foremost, I think here the important thing is that we are not prescriptive anymore. There was a question about, should it be institutions, should it be at home, should it be in what kind of care settings? We're increasingly evolving towards an understanding that it should be a choice, that there is not one solution, there's a diversity of preferences, and what the system is called to do is to offer a diverse mix of services and solutions so that every older person who needs care can choose the one that's right for them. To access community services and participate in activities that give their lives meaning. So again, we're not prescriptive in what those activities might mean, and it's important that we carry this understanding that if the goal of care is quality of life and dignity, that is personally defined, and it's always has to refer back to the preference of the individuals. So the mandate here, or the vision here, is to respond to individual needs as they arise and to design a system that has that inbuilt capacity and flexibility. Okay, so these are the 4 action areas. I won't talk about them much, just to say that I think what's important about the decade is that it really proposes a vision where these 4 action areas are interdependent and have to be promoted together. And this is very close, I think, to a public health approach to long-term care, and very much the message that I want to transmit today is that we, of course, need to define policy fields and service areas, and some borders and distinctions are necessary in practical implementation. But in fact, the boundaries between these fields, these services, these areas are really fuzzy, and there's a lot of overlap, and there should be a lot of overlap, and we should think of them interchangeably. Because our attitudes towards aging influence the way we design and think and interact with care. Care is co-produced, so our own attitudes towards our own aging will influence care outcomes. Ultimately, age-friendly environments, as Kai has mentioned, determine functioning, so determine the need of care. Integrated care here really highlights this aspect that long-term care, personal care, cannot really be separate neatly from medical and healthcare needs, and there's a lot of overlap I'll talk about. And finally, long-term care comes into that mix, and all these things need to be promoted together. Yes, jump in, please. I need to keep an eye on time, actually.
Sorry.
Not at all.
Interrupt you, but I just have a question. Is there a contradiction or conflict that you are putting that your vision is to putting the older people at the center and the core of that what you are doing, but you are collaborating with municipalities, institutions, and organizations?
Well, The goal is to collaborate with older people and to have them fully engaged in this process. Throughout the decade activities, but also in WHO's own activities at all levels, we always interact with organizations that represent older people, hopefully with older people themselves, whenever that is possible. I can be honest and say we can do better on these aspects, but it's certainly part of how the decade and all our work is designed and the way we try to implement it. Now, yeah, again, it's easy to put older people at the center and then work around the center, and it tends to happen, but it's not. That's not the hope. It's not the vision. It's not. I would think what we do. Yeah. So I think I would have some slides on that eventually, but when we say stakeholders, yes, our first mandate and our first reference in a country are national authorities and regional authorities. We interact with care professionals and care provider organizations, but we are also very closely linked with civil society organizations. WHO has a whole host of non-state actors that are accredited and can participate in all high-level meetings, assemblies, decision-making bodies. That's one mechanism, but also on the ground, this is something we try very much to do. Is that an answer? Yeah. Okay. Right. So how are we hoping that this might happen? This ambitious vision of the decade, where there are 4 enablers that the decade highlights. And I think as many opportunities for researchers and for people working close to research to participate and interact with the decade. I'll start at the end: strengthen data research and innovation to accelerate implementation. We absolutely need more evidence. We do have, I think, a very good idea of what works and what doesn't work. We need more contextualized evidence. We cannot constantly rely on data from a few countries that do a good job at collecting information and data in their own systems. We need better contextualized data, especially if our goal is global. We need to connect stakeholders, and stakeholders, again, thank you for that question, absolutely must include older people, civil society organizations, associations on the ground. It must include researchers, it must include authorities, it must include policymakers at all levels. Building capacity. What's happening here is building capacity, but you can, in your own roles, build awareness and build capacity, and hopefully that's something that you will do as you progress to your research. And finally, listen to diverse voices and enable meaningful engagement. Again, coming back to this question, this becomes increasingly harder to do as you go to more aggregated policy levels, but we do rely on research to engage closer to the ground with diverse voices and to try to bring into the discussion underrepresented minority groups, vulnerable groups. So hopefully this is something that, again, you can pick up in your own work and contribute to. So you might know about the platform. I'm not going to spend a lot of time on this. It's a good source of information about the decade and the fantastic repository of knowledge. If you have questions about long-term care, many of the questions you asked today, you can answer by going to the Find Knowledge link here. And there are, by now, I think, thousands of publications and resources listed there, definitely in the higher hundreds. And I do encourage you to also look at the progress report of the decade that was published late last year. What it aims to do is to inspire and motivate stakeholders to collaborate in their continued efforts to implement the decade. I think it comes very, very close to that goal. I found it inspirational. I found it interesting. You'll see a lot of practical examples and from around the world, really. And I think you'll get a lot of good ideas that can help you in refining your own work. Now, let me spend just a few minutes on the European Care Strategy, but if there are any questions on the decade or, well, okay, we can come back to it. Now, the European Care Strategy, I don't know how much you know about this. I'm also not necessarily the right person to talk about it in detail, but I want to highlight a few things. So the European Care Strategy looks at and applies only to the European Union states. It's an EU initiative. Importantly, it's focused on supporting and protecting care users and caregivers. This is, I think, really important, and it moves us more and more towards a direction where we look and understand care as a relational, dyadic, if you want, process. We need to worry about and protect and support both the people who need care and the people who provide it. And Kai has hinted at the many, many issues that we see for caregivers today. Now, it looks at the care in a lifelong perspective. So it starts with early childhood education. You know, there's a much stronger tradition for policymaking and support at European level for childhood education. We have the Barcelona targets, they're being revised. In long-term care, this has not been the case. So the care strategy is a first very important step in this field. And it looks at building synergies with other related EU initiatives. Why is that essential? And it really is essential because the European Union, very much like other international organizations, does not have a mandate for policymaking and decision-making in long-term care or in healthcare. That mandate rests with national states. So it's important to understand that while the European Union can be an active player to move the field and to incentivize it in different ways, it cannot direct states in their own individual decisions, nor can it direct regions or any other governance level. So what does the European care strategy comprise? It's a whole care package. I won't talk about it. There were a series of reports and efforts of data collection. And I do encourage you to look at the long-term care report and the country profiles there. It's quite insightful. But it also came with a council recommendation on access to affordable, high-quality long-term care. And I've underlined the word recommendation. This is the highest power instrument the EU has in the field of long-term care. There is not going to be a directive on long-term care because this is just not a European mandate. Yeah. So council recommendation, we've pretty much come as far as we could in this field. But there are other opportunities through other policy fields, and hopefully we can hint at that. What does the recommendation look at? It looks at affordability of care. It's a big, big issue. Kai mentioned it. It looks at availability of care, another big, big issue. And when we say availability, we should think in terms of capacity of services, but also diversity of services. Yeah. So if all that is available is residential care or facility-based care, and that is not something I want, it doesn't matter how many free places there are. The care I need and I want is not there, is not available. Availability has a really important aspect that has to do with geographical distribution. Kai again hinted at it. We see that many areas that have very high needs of care, especially in rural and remote areas, are underserved or completely unserved. We talk about medical deserts in healthcare. We can talk about care deserts. They're definitely more widespread throughout Europe. So there are many aspects to the availability challenge. Now there's quality. Quality raised a few questions here, and this very thorny and difficult area, because if we do not have a clear understanding of what the needs and standards are, it's very different to define quality. Kai mentioned it's counterproductive even to try to standardize too much what good quality means, because it is referential to the person's own preferences. So is it that we want indicators like prevalence of bed sores that's been very frequently used for facility-based care? Yes, that tells us something, but is that really the quality and value of care? And is that care outcome that users find meaningful? Difficult field. I hope some of you are brave enough to step in and help us along with it. And finally, carers. Yeah, carers, both formal and informal. I'll come back to this a little bit, but we have enormous issues with ensuring a workforce, both formal and informal, for care. And it is absolutely at European level, and certainly in global perspective as well, the bottleneck and the priority for care. And hopefully we can talk a little bit more about it. Okay, so EU level actions, I will not go through it, just to say the EU is trying to do quite a bit about it. There are many opportunities here for research to interact. Everything that says Horizon Europe, this is a research funding, but many of the other funding streams that that are closer to policymakers or that open resources and opportunities for collaborations for national authorities have functions of technical support. So researchers are often invited to provide knowledge and collaborate with local and national authorities, and please look into that. Funding is the big one, yeah. So as in so many other things, resources really change the field. So what the EU can and is trying to do is to change the funding availability. So certain policy areas are pushed forward. This is a very, very short overview, but just to get a sense of what's out there, through the Resilience and Reform Program, 7.3 billion have gone to member states to support long-term care reform. Not every member state has chosen long-term care as one of the areas of investment, but many have, 18 out of 27. This is an important stream of resources that hopefully will make a difference. The ESF funding, the European Social Fund, is increasing its opportunities for funding long-term care. This is not available to researchers. This targets national and local authorities. But again, it's a way to fund service development. It's a way to fund pilots. And researchers have a role in designing, in monitoring, in evaluating, and showing the impact of such program. And hopefully you can engage with that. Social innovation in LTC, this is a collaboration where researchers can participate in funding, and the technical support instrument is again targeted at national level, but it is very much about technical know-how, about evidence building, capacity building. So there's an important role for knowledge brokers and for researchers to play in this project. Okay, that was it on the high-level policy interventions, and I'm going to move to a public health approach to care and WHO's own evolving definition, unless there are questions. Yes, I don't have a microphone. Right behind the queue.
Thank you very much for this amazing presentation. My topic of my PhD is about the inclusion of voice of older people into urban social policy. So I'm a bit interested to make question with that regard. And the question that I had was, if you do have any special mechanism that you include the older people voice into your policy, especially about diverse groups, and if the inclusion is happening at just developing the policy with advising the policy, or happens like consistency, that you supervise, like as a unit of World Health Organization, you supervise the implementation process, and if they are involved in the whole process. And thank you very much.
Yes, the short answer is no. The long answer is yes, there are mechanisms, and again, at the level I work at, and even higher aggregation level, so for the decade, for the European Care Strategy, most interactions would happen through representative organizations, through NGOs. And at European level, there are very strong umbrella organizations that represent caregivers. Kai mentioned Eurocare's Age Platform is another umbrella organization that practically brings together all national, local organizations that represent older people and tries to aggregate their voice. They are very closely involved in this project. Many social partners have been very closely involved, and I have to say it's been I don't know, people who have worked in the field can contradict me, but I think many of us did not hope for such an ambitious and open-minded care strategy as a first step for long-term care at European level. I think it really shows that there was so much grassroots involvement, and that there was a strong voice of older people that shifted a little bit, the scope, the focus, and the vision of it. So is this the standard? Again, I'm hard pressed to say. We definitely can do better, and I can tell you in my own work, we try to make a point of making sure that whenever we have events, whenever we have meetings, whenever we have expert and validation groups, we include older persons. It's often harder than you think because of the bureaucracy, because of the structure, because, we want to run our meetings in a certain way and we expect them to adapt to it rather than redesigning the way we run policy meetings so that older people can participate more meaningfully. I had a good conversation about this with Kieran in Dublin, not even a month ago. There's a lot more we can do, but it's a process, is the best I can say. So in the meanwhile, I really do believe that we rely a lot on researchers and on NGOs to collect these messages, to collect these voices, and act as a loudspeaker, to bring them, to reshape them in a form that can be impactful. in the policy process as it now works. And we can hope to transform these policy processes. I think other people here are better positioned to speak about how this change is happening at local level, and maybe Elizabeth will. We're looking forward to that, but we're not necessarily in the best position to make that change happen.
There is a second question.
Yeah.
Thank you, Linka. I wanted to know from your opinion, to what extent does the European care strategy reflect or incorporate a rights-based approach to long-term care? And if it doesn't, what are the key challenges to accomplish that, and also to do that at the national level? Thank you.
Yeah, again, it's not designed to do that. It's not an instrument the EU has and can deploy, but I think in the spirit of it, it does. And it is presented, and it has been launched as a follow-up on the European Pillar of Social Rights. It's very closely linked in its monitoring and implementation with the European Pillar of Social Rights. So it is grounded in a belief that there is an individual right, and as part of our social policy, we should recognize a right to care linked to dignity and quality of life and health. But it's just not the right instrument to go all the way into codifying that, maybe is the word. I'm not sure. Hopefully it is a trigger for some countries. So you can also, if you look at the targets and if you look at most of the work that's being done under the strategy, there's a strong push towards improving social protection and improving affordability of long-term care. But there cannot be a message that every country needs to fully cover and ensure access to without financial burden. So again, I think it's inspired by a rights-based approach, and it's helping promote an understanding that is aligned with the rights-based approach, but it's not the right instrument. No? Okay, one more question there.
Hello, it's my name is Patricia Conboy, and I previously worked with HelpAge International. So I actually don't want to ask a question, but just to make a comment that reinforces what you've been saying to the participants. So HelpAge was an organization, still is, that has accredited status with World Health Organization. Right. And the way in which things worked when I was working with HelpAge was that, apart from the attendance at meetings and all of the things that you've spoken at, you know, the assembly, etc., that when, say, the decade was being developed, when there was discussion around what does ageism mean, how might it be understood in different parts of the world and so on, through the HelpAge network of older people's groups and partner organizations in low and middle income countries, there were, you know, very sort of authentic attempts and initiatives to gather data and to gather feedback directly from older people in different circumstances, and to feed that back to colleagues in the World Health Organization, as well as to have representatives whom we had worked with in the field at different meetings. So just by way of, you know, validating what you're saying, but from the other side of the fence. Thanks very much. It's a fantastic presentation.
No, thank you for saying that. And I hope you would agree that we're improving a little bit. Yeah, maybe not. It's never quite as fast as you'd want, but yeah, at the very least, I think it is at least recognized as an explicit focus in all of our work, and maybe that's going to be the trigger to really shift things. Okay, a public health approach to long-term care. Giovanni, when do we end?
We have time and officially until 1.
Okay.
We may have some minutes of flexibility.
Okay, so what I'll do is anyway leave these slides with Kieran and with Giovanni, and there's much more content than we can cover today. Look through it, write if there are details that you're interested in, and there are a few resources that are signposted here that I think can really help you. So again, how do we understand long-term care from a public health approach? And I think all of you would be familiar with the discourse around healthy aging, and Kai mentioned this already. So a need for care really is about functioning. Yeah, it's not about health needs. It doesn't matter where these needs arise, but really what happens especially as people age. And this is not really an aging process, but it's a biological disease-related process. As people age, the prevalence increases. Their intrinsic capacity, so their intrinsic capacity means your own individual physical and mental abilities will decline. Now, depending on the environment that you are based in, that might or might not mean that you're less able to function. So really, it's about your functional abilities and interaction between your individual capacity and the environment that you are supposed to function in. So in a small supportive community that's fully accessible, that has a strong knit social structure, a person with dementia, a person who gets confused, a person who's a bit slower in their movements will still be able to be independent, especially if their houses are not on the 17th floor without an elevator and all kinds of other barriers. So very much the point really here is that healthy aging and care needs are about the interaction between your own ability and the environment that you are functioning in. And why is this important? Because this here, where the little arrows are, that is where our ability to intervene resides, right? So can we do a lot about declines in intrinsic capacity? Yes, now more than ever, we have medicines and treatments that are delaying and even reducing capacity decline, although there's an argument around that. But we certainly can put in place supports, and we can certainly make environmental adaptations that narrow this gap so that whatever your intrinsic capacity is, you can still remain independent and function effectively in an environment. So WHO proposes this vision of what long-term care is all the supports, all the services, all the resources we can put in place so that despite declines in intrinsic capacity, people can maintain quality of life, can maintain independence, can maintain dignity, and fulfill their human rights. And what does this mean? Well, at different points through the life course, it will mean different things. Yeah? But it certainly includes many aspects that are generally not associated with long-term care. So the big pushback that we're trying to put in place here is a vision of long-term care that is reactive and that is passive. And I've used this expression that many people think long-term care is what you do when there's nothing else you can do. And unfortunately, it's still seen like that. It's seen so much as end-of-life support for maintaining minimum dignity. And it can be so much more, right? There's a preventive aspect that goes to it. Yeah, we can prevent functional decline. There's a secondary prevention aspect. Even if functional decline, intrinsic capacity loss install, we can still make sure that the effects are not quite as dramatic as they might be. We can certainly try to reverse it. And there's more and more evidence that there is scope for rehabilitation for many of the conditions that lead to older people losing intrinsic capacity and functional decline. But we certainly need to have all these services in place. Assistive care and caregiver support. Again, I cannot tell you how important it is to me and how much of a step forward I think it is that these words are said in the same breath, that we look at care for caregivers and older people with care needs as one unified package, and then palliative and end-of-life care, because I think it's really important that this culturally can be difficult in some settings, but I think it's important that we talk about quality of life and quality of death, and that we make sure that there is a good understanding about how these things can happen together. So this is the theory of it. The practice looks much more like this. This is one example contributed by our colleague Matteo Cesari. It's just one example of an older person, right? And this is more or less typical, but I think it does give a sense of the fact that long-term care is also, and the need for care is not this irreversible, slow, continuous decline. And in fact, it's one of the risks that most of us underestimate very significantly. It's about 1 in 2 people will at some point need long-term care during their life course. It might not be forever, it might not be continuous. Again, you can reverse, you can recuperate, there's a lot you can do, but it will probably be a reality for many of us, and it is a reality for many older people today. And what interventions we put in place, also matter a lot, right? Because providing access to walking aids or to mobility aids or to all kinds of other assistive technologies that help people function better and improve self-care, that reduces need for services. And it is a long-term care intervention in this sense, right? Just as it is to modify the personal private living environment. Home modification, they are an intervention for long-term care, but they're also very closely linked to housing policies and accessibility policies. So again, these boundaries are really blurred, and it is important that we think of all these services as supporting what is important. Dignity, quality of life, functioning, independence for older. Now, this is the definition that long-term that WHO proposes for long-term care, updated to 2021. It's constantly evolving, but there's important wording here: broad range of personal, social, medical services and supports. So it's not just care services that makes long-term care really important. Maintain functional ability, bringing it back to basic rights and human dignity, talking about a rights-based approach. And there's wording in several policy documents by WHO that I think is really important, that the goal of long-term care is to help people continue to do the things that are meaningful for them and that they have reason to value. Again, not prescriptive, but very person-centered. This is what person-centeredness means in practice. And again, attain the highest possible quality of life and quality of death. So it's a continuum of care services that goes from prevention all the way to assisted care and palliative care. And if these services work well together, then that's quality, and that will improve quality of life. So I want to say 2 words about an upcoming publication from WHO that we're really hoping is going to be a game changer, because part of what's making data collection difficult is that many of these terms are vague, and at national level, they're operationalized in very, very different ways. So WHO has been working for a long time, and my colleagues have done an amazing job trying to come up with a global package of core long-term care intervention. The idea being that there is a minimum basic set of supports and care services that need to be in place and that should be aligned with universal health coverage, because they're essential to attain the right to health of every individual. And this is a brief overview. So this is coming out hopefully at the end of this month. This is a brief overview of what it includes. It bridges across health services that can be considered more healthcare oriented, services that are more so oriented to social care and support, and services that are more oriented on palliative care. And it also brings in this message that a key function of long-term care systems is to provide support for older people with care needs, but also for their family caregivers. Family caregivers, informal caregivers, whatever the terminology used, are target groups in themselves. They're people with care and support needs as well, aside from the fact that many of them tend to be older people themselves. So, they should be protected and supported anyway. What I think this does to accelerate progress, strong basis for advocacy. It does have the benefit of linking long-term care to other complementary policy fields. I think there's strength in numbers, and there really is scope for aligning advocacy agendas so that we can try to promote progress. This vision of long-term care links with universal health coverage agenda, well-established, fairly well-funded, with the healthy aging agenda, which is much broader, but it is supportive and complementary, with the disability inclusion and inclusive services and environments agenda, again, with a very, very strong advocacy history and great, I think, achievements and successes on the international policy stage. So hopefully by aligning with all these policy agendas, and I should also mention gender equity. The gender equality agenda has been essential in promoting the European care strategy to the level it's been, and it is great that it has. And now this does not mean to say there are no conflicts and no complexities that arise from trying to embrace too much and put too much together. That always is the case, but there definitely is a situation, I think, now in the international policy field where we need to take every opportunity we have, because a window of opportunity has opened and we make the best we can out of it. It's probably not going to last forever. It never has for any other policy field. So we try our best to move things forward as quickly as we can. What else I'll say, a prevention-oriented approach to care. I think this public health approach to long-term care gives us scope to talk about not only responding to, but preventing, delaying, and reversing functional decline, which is what health and long-term care systems should do. This is the difference between ministries for disease or systems for disease and systems for health. We keep reacting and don't do great at preventing and reversing. And then a life course approach that gives us mandate for early intervention. Because if this vision is the way we're supposed to go forward, it does really signpost that the earlier you step in, the earlier you support people, the less likely they are to decline rapidly, to need more intensive care, and to ultimately lose quality of life in the aggregate. Okay, what does this mean in terms of system conceptualization? So Kai showed you a very busy graph. I'm going to show you another one. The idea here really is exactly the same, that we cannot put long-term care in a box. We're always going to fight about what the box is and where the edges are. And we are increasingly moving to a conceptualization of care ecosystems. Care ecosystems that have a component that is formalized, formal care service delivery, a component that is bigger, wider, more comprehensive, that is informal care and support in communities, an even bigger context in which they operate. This is the communities, the environments, and you cannot separate the two. And then at the edges, the long-term care has in many countries developed as a social policy welfare field, and we are living up, unfortunately, both with the benefits and the downsides of this history. But there's clearly a health-related component to it. The goal is never to medicalize long-term care and to make it another branch of health systems, but to find a balance and to find a way to manage effectively these overlaps so that we don't end up with enormous, huge, consolidated ministries for everything or systems for everything, but we find out ways to coordinate across these system boundaries. Now, easier said than done, but that is very much the vision around it. And I do want to highlight here caregiver support, key function of long-term care, social participation support, key function of long-term care, personal care, also part of it. And there is a role here for assistive technologies, for innovation, for improving self-care as well. So looking at long-term care, not only at what we can do for older people, but how can we empower them so that they maintain their independence and abilities. I'll skip this. So these are resources you can look through. They really bring the health and long-term care discourses closer together. You can find them useful or not. I'll end on this maybe. Just to say this is a synthetic version of our work plan at the WHO European region for the next years. And this graph has come out of consultation with focal points in all our countries, with the national long-term care coordinators that have been nominated for all EU countries and are meeting regularly, with experts in the field. This is the mandate because we don't set our own work. We're supposed to support countries with what they need. And this is what we're told countries need support with. Informal caregivers and care workforce is by far the biggest priority. I think the last data for the EU is that 2 in 3 countries reported both severe and widespread shortages of personnel in long-term care. So that means that virtually every provider is facing shortages and every type of provider, and they're severe. It means that a high share of open positions are not being filled. Informal caregivers, the same. If you look at the data coming out after the pandemic, Eurocares has published on this, many countries have published data. It is a public health emergency. We need to support people with mental health, with physical health, and to react to this. Everything else is secondary. This is the narrowest bottleneck there is right now. And Kai has mentioned international mobility. We've always looked at that international mobility as a solution to fill these gaps. Now there's an ethical aspect to that we need to address. Kai mentioned that. But there's also just a logical gap in there. This is not a forever solution. We cannot constantly keep passing the buck further east or further west, because eventually you end up in an ocean. It's just not sustainable. So we need to interrogate what it is that leads to these problems. And the elephant in the room here is that the health and care workforce overlap to a considerable extent. So we are in a situation where we're seeing the same shortages in the health workforce. Because we're in Italy, the data for Italy is that more than 1 in 2 doctors, and I think it's 1 in 4 nurses, is aged today 55 or older. It means that in the next 10 years, half of the doctors in Italy will retire. And in 10 years, even if you start now, you cannot train sufficient doctors to fill that gap, let alone to ensure the increase that is needed to respond to growing needs. So this is an enormous issue today, and it's going to get bigger before it gets easier to do. Everything else is also really, really important, but I think secondary to this, financing is a big thing, quality management is a big thing, and these are all areas of work that we are trying to address. So I'm going to stop here. I was going to talk about many other things, but I'll leave that with you, and maybe we can have a discussion about where you'd be interested to contribute to, where you see your work fitting in, and anything else that you might want to ask. Thank you.
Thank you very much, Stefania. Floor is open for questions. I see one here.
Hi, thank you. I'm Fatima Hatami. I'm a doctoral researcher in Finland, Tampere University. Actually, my background is in transportation. So I was thinking that sometimes when you are in transportation, government doesn't build some facilities, for example, for cycling, because they think that, okay, people don't cycle, and people say that we want to cycle, but there is no infrastructure. And this argue goes on until, I don't know, someone just quit. And I think that that's maybe because you talked about availability. And I think that could be an issue for people who are like in terror deserts or are living in rural areas. Do you have something that can address this problem, to just have something in between, or the government provide something? I don't know. Do you have something for that?
Do we? Help me out from the room here. I don't know how to answer that. I mean, we're trying. I think we have a lot to look at. I think there are many countries, many good examples where people are trying to pilot things, to have these proofs of concepts in place, so that you move the needle along. A lot of European funding that has gone into supporting long-term care has had this approach, this mentality. Let's show that something can work, and then maybe it's taken up, so that you kind of break this stalemate. You can't prove it's good until you try it, but you can't try it until you prove it's good. And I think we're constantly, in this trade-off. But to what extent this is a solution, I don't know. We've done a little bit of work. Kai can also talk to this about transferability, and do you have solutions that you can take everywhere? No, we don't. We find actually that it's such a contextualized field and that, you know, success of what works in one place depends on it being designed to work in that place and to build on the resources of the community and that are available there. So many times we've had great ideas that we have not managed to replicate. Part of the work we're meant to do is to share good ideas and to work with national authorities to adapt them. Yeah, again, easier said than done. But I don't think there is such a thing as I think we can confidently say, based on the evidence we have, that we know what direction service delivery should take. But are we in a place where we have consensus on do A, B, C, D on financing, on service design? I don't think we're there, and I don't think we're ever going to get there because it's so context specific, and that's part of the balance we're trying to find here. I don't know, Kai, do you want to add anything to that?
At just for the younger people here, because we were brought up in a world where there was still something called social planning, and this has disappeared with market-oriented plans and so on. So also. Don't think we can go back to that. Say, okay, you need one care home per 1,000 inhabitants. That just doesn't make sense. So this is here, but we need something that then, yeah, in the local context, is trying to go in this direction. But here we come back to this, yeah, to the current governance, where you have also private investors who just build it. It's very defensive there. Yeah. So how can you steer this from international initiative like so here it is really all down pilot projects here and there, and yeah, we are using the term learning from each other. Do we really have good examples where this learning from each other really works? I think this would be also an important question. We have so many pilot projects, we have so many also in the meantime conferences and possibilities to change. But then what is really happening? This trickle down effect is very, but I think an interesting research.
Yeah, if there are any takers. Yeah, please.
Notice like most of
It's not working. I don't hear you either. Yes, now
I continue. So it's focused on older people and the caregivers. And I was wondering if there is like some kind of interventions. I read like some local capacity building and social participation support, but specifically for common public to make the intervention more like sustainable, in a sense that the like common public can be more like in by acknowledging the issue that we have in aging, and like for example, when it comes to some issue like ageism, combating it, then we have better participation from that side. If the model is covering any intervention for common public, or it has been any intervention, I would appreciate it.
Oh God, you're not gonna make this easy for me, right? I don't even know where to start, to be honest. Okay, I'll be challenging back. So it's probably one of the areas we have least evidence in to show that public information campaigns actually help us move the needle. So we've assumed for a long time that what it is people need is more information, and if they would know, they would just do it. And we're increasingly learning in health, as we are in care and in many important social aspects, that it is not so much the lack of information, but the systemic constraints that people face. So this idea that it is so much about individual control, and all we need is to put information out there, I think is not standing anymore. Not to say it's not valuable. And I think if you look at what the global campaign on combating ageism has achieved, you can show that opinions need to change, values, visions change, and these can be triggers. But probably it's a long shadow down the line. Are we seeing now that campaign has completely changed the policy discourse at local level? I don't think so. Yeah, it's a difficult question. We try to do this. I think every aspect of the work we do has a component of public communication and awareness raising. So you'll see that on every topic area the WHO works in, we have a series of technical documents that are about the care practice and the evidence base that's specific, to medical or care tasks. And then we have policy documents that are really about the policy dynamic. And then we always have news stories, information sheets that target more the public. Yeah, I don't know, we're constantly asked to show the impact of our work, and I don't know that we have managed to do that. I don't know that there's a way to do that really, because if there is a real impact, it's probably way further down the road than when the project or work ends. And you're going to face this in your own research work. You're going to be asked, what is the impact of the work you did? And you haven't even finished the work and you're supposed to know. So yeah, I don't know how to answer that question. I don't want to cop out of it. I think it's a valid point, but it's part of what we do. It's not the main focus, and it's also, especially at the regional level. And I wouldn't pin all my hopes on more awareness and information. I think there's a lot we need to do in changing systems, changing the constraints people face. Yeah.
There is one more question with a good micro, please.
Very passionate about this field.
Very good to hear.
Ilinka, I really appreciated your last point because you were very honest about one of the biggest issues being the shortage care workers in many countries. And I think we've known that for a while. But for some reason, might be politically controversial decisions, it's very slow, the response, what to do on this and the opportunities that international mobility might offer for an answer. So I wanted to, if you could elaborate a little bit more, if the WHO has a position on, or further direction on that. If there are any examples of countries that are already doing anything as far as policy action to address this shortage of care workers, which is such an important issue.
So WHO is trying to do quite a bit, and not surprisingly, given its mandate, WHO focuses and has started this work focusing on the health workforce, right? So you've heard me talk about doctors and nurses. It's not only that's the core WHO mandate, it's also that's where we have information. So we are facing a situation in care now where we know there are shortages because providers tell us we have all these vacancies we cannot fill. Or in a country like Ireland, you have funding for more services than you can deliver because you cannot find the people to actually deliver those services. And there's no care without caregiving. Yeah, again, relational, fully through and through, almost to a one-to-one proportion. But what WHO is actively trying to do right now, first of all, to build the evidence base on and to talk about a health and care workforce, to think about what it means and how it can work with countries to do integrated health and care workforce planning, This has been going on for a long time. Yeah, I mean, we're improving. I think it's harder than it seems. The issue of international mobility of a care workforce has been addressed in the context of health. We have an ethical recruitment standard that is supposed to be global, and there are countries that are red listed and no one should recruit there. There is a history to this. The extent to which it's actually being applied and expanded to care is limited. There's an ongoing discussion about how that could happen. It's a really, really big discussion to be had, and it's a very political discussion when it comes to care. But stepping back from WHO role, when Kai was speaking, I'm originally from Romania, and when Kai was speaking about the situation of live-in caregivers, you know, it hit very close to home. And we are actually trying to, at the very least, move to a place where this workforce is recognized as a workforce. Austria is an exception in that. Yeah? People in these positions are often not part of any kind of workforce statistics because they're not officially part of the workforce. And you know what happens when that's the case? They have no rights, no protection, no social protection themselves. I just had an interview not a week back with a 24-hour carer from Romania. She's been working for 20 years in this field in several European countries. And she was saying, you know, I'm close to retirement myself, and I realize I'm going to go back to Romania where I have no protection. I'm not going to get care. I'm actually facing old age poverty, and I have no rights in the countries I work with. So this is what's happening to the people who are providing care today. They're facing a future where there's no care and support for them. And we don't even see them in any of these statistics because they're not part of the workforce officially. These are really significant issues, yeah? Yeah, we're doing better. You know, we're talking about it in fora like this. And if you guys come up with the research and the numbers and help us put this on the agenda more and more, we're going to make progress. I think, again, I have to commend the EU. They're really stepping into this field as well. With respect to labor relations, the EU does have a strong mandate. So they are looking into this and you know, employment and working conditions in the long-term care sector, to what extent minimum standards and EU legislation and rights are enforced. They're going to be looking specifically in the situation of live-in cares. How does this square with employment and social protection regulation in the EU? Can the EU say something about this? This is extremely important. It's going to take a long time. There's going to be a lot of pushback, political negotiation in the middle. But it is happening. Is it happening in time? I don't know. You know, in 10 years, we're facing falling off. And we cannot recruit in so many countries, even people to fill in nursing positions in university. So yeah, care is, yeah, I mean, Kai can talk much more about that than I can. But again, I think the situation is quite desperate. Anything people can do to raise awareness, to put the information out there, to come up with solutions, and to do so in an ethical way, keeping equity at the core of this. Yeah, that would be a very important contribution. Yeah, thank you.
Thank you. Thank you again for.
Thank you.
Thank you, Stefania, for this passionate also invitation you gave at the end of your speech. And I didn't even ask for further questions because we do need some break before starting again at 2. But please use also the break, of course, to approach Stefania in case you have additional questions. Again, thank you to you and Kai for this very interesting morning. Thank you.
No, we wait a minute for. Try again. So it's time to start the afternoon session now with Professor Rose Gilroy from the Newcastle University, Professor of Aging, Policy and Planning. In contrast to this morning, Rose will focus much more on the voice of older people and how to listen to them, how to incorporate it She is, apart from being a professor, founder of the Future Homes Alliance community interest company that will be building intergenerational dwellings, and chair of Newcastle's age-friendly city working group, among many other things. She's an expert in aspects of aging in relation to housing planning, about how home and neighborhood supports or can support quality of life, and how people individually and collectively may influence their environments. She has built this expertise not only in the UK, but also in Japan and India and China, not to forget, and she has considerable research experience in qualitative and participatory methods, interviews, focus groups, photo elicitation and visioning. Wow, these things, I'm very much looking forward to hear more about that. So the lecture today will explore inclusive participatory strategies in the design and development of service and support systems for older people, as well as the challenges and pitfalls regarding such strategies. As such, it's very much a complementary lecture to what we heard this morning about structural and systemic understanding of policies and long-term care systems. Here we also look at possibilities of older people themselves to use their voices and rights. Before I give you the floor, Rose, I would like to say that this session will now end not 3:15, but a bit later, close to 3:30, just to catch up with the quarter that we missed. And that is all for now. The floor is yours, Rose.
Okay. Thank you, Maria. Are you catching this, Christine? And is everybody okay with the sound? Right. Good afternoon, everyone. Marvelous to be in a country that's warm and even dry. We are flooding in our city, in fact, flooding in my back garden. So remember when global warming, we thought it meant buying suntan lotion, but clearly we were all completely wrong about that. This is quite a hard act to follow. The two presentations this morning I thought were excellent. I learned a great deal from them. And I thought what characterized both of them was a high degree of honesty. You know, things are not good and let's just get it out on the table, because if we don't acknowledge that, then we can't really start to do much about it. What I want to do in this presentation is really think about, if you wait for somebody to invite you to participate, you could grow old and disappointed. What you need to do is go and bang on the door and make them listen to you. So really that's the takeaway point from this talk. I may say that when Kieran asked me to do this, I had a number of false starts and kept thinking, oh, well, this isn't it. So now I've decided the other two presentations were talking at a higher and a strategic and cross-European level. I'm going to talk really about what's happening in one small city. So it's a very big change of focus. Oh, you're pushing the wrong thing, Rose. Hold on. What am I doing? There's a mouse. There's a mouse. Yes, that's fine. Right, relax. Good. I want to jump in and think, because I think there is more involvement from older people, particularly perhaps on issues about housing and place. We might want to raise the question about why that is. And this is just a few thoughts, and this is a presentation of 30 minutes, so I don't have time to dig very deeply into this. But we might think about this whole idea of the baby boomer. I must admit, I'm a little uncertain about these kind of generational labels, because I think you think, oh, well, baby boomers look like this and feel like this, and you think, oh, that's never been true. But one of the things which is meant to characterize the boomers, and we might think this is also challengeable, is this idea that this is a group of people who want more voice, who look at the offer which was made perhaps to their parents and think, well, that's not good enough. And they are in expectation of more and are going to bang on the door until somebody pays some attention to them. So we might say this is a generation with more expectation of having a say. We might also point to the age-friendly city movement, which, if you remember, in 2007, the initial 33 cities The whole framework was built upon the strong involvement, the voice, the opinions of older persons, their organizations, carers, groups, and a whole lot of people who were working in this space. And that remains fundamental to any city or community which is thinking about working towards being an age-friendly community. And I think the thing about an age-friendly community is not only is it built upon the voice of older people talking about their experience and their aspiration, but it also then creates greater opportunity, because this is not just about place, about transportation. It's also about civic participation, social inclusion, bringing in more people. So a commitment to, if you want, people being active citizens. And we might tap in, of course, to people like Lefebvre, the idea of the right to the city, which is much more than the right to simply occupy a space. It's also the idea of having a voice in its making. And thinking about David Harvey, and I really like this quote, that the freedom to make and remake our cities ourselves is one of the most precious and neglected human rights. We don't often take up the right, even when it's offered. The two presenters this morning both took you through models, so I thought it might be quite useful to also look at another model. And this looks not really at an evolution, but it looks at three different perspectives. And we might think about the medical model with its focus on the individual patient. And you'd like to think these things are changing, but you know, if you talk to medical people, certainly if I talk to medical people in my university, I think older people are just a bundle of conditions. You know, as James Smith, type 1 diabetes, occasional confusion, osteoarthritis, not Jane Smith, singer in our local choir, best gingerbread maker in the parish, loves Cary Grant films, you know, tells a good bedtime story. What makes a person is kind of expunged from their thinking. So it's a focus on an individual, it's about a clinical intervention, and it's about prevention of entry into hospital. And clearly now we get into the economics of it, because going into hospital is an expensive resource. And speaking from a British perspective, things are not well in the state of health. If we move on to a care perspective, the social care arena, which is clearly a large one, we can think about this idea of a customer. I must admit, I'm not terribly comfortable about those kinds of labels either, because it suggests, you know, if you go to Marks and Spencer's and you think their apples look a bit poor, you can go to somewhere else and buy some fresher ones. Is that really the experience when you're in a person who might need social care? Is there that much choice around? And I appreciated the two perspectives this morning by saying that, you know, there's a lot of things need to happen. There's a lot of structural constraint, and you might have choices in notionally choices, but when you come to exercise them, they're not really there. But I think what is supposed to happen, and again, this discussion of this morning, is a broadening from the individual to an understanding of the ecology of care. So you've not just got Mrs. Smith, you've got her son who lives on the other side of the city, her daughter who lives 200 miles away, her good neighbors, her reading group, and the people who form that kind of network of love and support around this particular lady. Again, this is good practice. What happens on the ground is not necessarily the same. And the intention here is to prevent, again, something which is costly, entry into the care system. But if we move to the idea of citizenship, and this is really embedded, I think, in the idea of age-friendly cities, the person is a citizen. And the focus is not on the person or even on their network. It's about this role of place. And I like this because it suggests that there is a responsibility on all of us as individuals, as placemakers, as urban designers, architects, retailers, everybody out there has a responsibility to make this a good place, not just for older people, but for children, for working age adults, for students, for everybody, because there is only one city. If it's age friendly, it's got to be age friendly for everybody. And the idea is about promoting social capital, reducing social exclusion, and changing social structures and attitudes. I want to pause now because I was thinking, how have we done? This is very much a UK focus. How have we done in bringing in older voices into this hugely important arena of housing? Because those of you doctoral students who are in the middle of doing your research, your literature reviews, I mean, housing is critical to us throughout our lives, the place to do your homework, the place to be safe, the place to come home to, the place to be in control. But as we get older and maybe other arenas start to shrink and maybe our life world becomes somewhat smaller, the quality of that particular housing becomes so much more critical. And therefore, you would think that older voices were really at the heart of our housing policy. And in the UK, we don't have a bad track record on this. And I think the start of this is really from the election of the Tony Blair government, what we call New Labour, because the Blair government came in with a promise that they would be a listening government. And there are a number of ways in which they made good on that promise. One is setting up the pilots, and I think there was 17, might be incorrect on that, Better Government for Older People projects around the country, which were really about trying to shift the balance of power and ensure that older people had a voice in local policy and had a conduit, if you want, into decision makers. And I want to pick up this a bit later, because I'm going to talk about the work of Newcastle's Better Government for Older People, which has now become Newcastle Elders Council. But there's also the Older Persons Advisory Group, and from that, the group called HOPDEV, Housing and Older People Development Group. Now, this was hugely influential because it was their discussion with a very charismatic and influential civil servant, which led to the development of the only, I think, strategy ever developed between health and housing ministries, which was Lifetime Homes, Lifetime Neighbourhoods. And that, I think, was hugely influential in having people think about this continuum, that there's no point in giving people decent housing if the social and physical infrastructure around them simply is non-existent. And we can also think about the HAPPY panel. I don't know whether students are aware of that. This is Housing Our Aging Population Panel for Innovation. If you go to the Housing Learning and Improvement Network, often shortened to Housing LIN, you can find all of those resources. And on the first HAPPY panel, a group of British stakeholders, which included older persons, Vera Bolter, who was by then chair of Newcastle's Better Government Project, was one of those people. And they looked at a range of housing from age-targeted housing through to housing with care, through to housing for persons living with dementia, right through to hospice, trying to draw good lessons from that, which could be mainstreamed. And this, again, has been hugely influential in raising standards. And I think what there is now is much better attention. And again, I would point doctoral students to the plethora of material which is out there, which is recognizing the fact that older people are not one thing. Obviously, there's a range of age, of ability, but this is a group cross-cut by ethnicity, marital status, income, sexuality, disability, caring responsibilities, and anything else that you care to put in mind. So there's been a lot of work, I think, raising awareness about the diversity of an aging group, and also the need to, as many people said this morning, to appreciate context. What do these people want. It's not what do older people want. There is no such thing as what do older people want. It's what does this group of people want. I would also, before I get into talking more locally, I would just point everybody to the resource of Architecture and Design Scotland, which is a really, really good resource. ADS Scotland, they have been working to what's called the Scottish Place Standard, but also the Scottish Government's commitment to put well-being at the heart of all policy. And that they've come up with this idea of caring place, which I really like. This idea that you should have, familiar surroundings, that you should feel needed, that you should have something to do in a sense of support, and that the place itself can both work on those principles and support people who need to feel, as we all do, supported by place and by community. So there's some really nice resources on ADS Scotland. And as I've been saying to some people in the breaks, there's no need to start from ground zero. There's a lot of super work out there, which you can look at and think if you could actually use those kinds of methods, or whether you could snip them a bit and alter them to your particular project. Right, I want to move on now, looking at the time, to think about Newcastle. So this is Newcastle's Elders Council, which was better government for older people, which became Better Life and Later Life, which became the Quality of Life Partnership, which has become Newcastle Elders Council. And really, Newcastle Elders Council is a group of older activists who do their own research and bring their findings into local government, and if you want, have demanded a seat at the table. And I want to talk you through a few of those kinds of projects and some of the things I've been involved in or been inspired by Elders Council to take part in. And of course, this is not just about one organization, because nobody can lift the world on their own. It just doesn't happen. What you need is to have strong partnership, political support, friends and allies within the local authority, within the university. I mean, we have Tina Buffel here from Manchester, and the strong support from Manchester University to people in Manchester and older people about forging this age-friendly city together. So this was the first project I got involved in, the House for Life, and I even wrote it up for Aging in Society. I think what we take away from this is it's important to do something, to take action. At this point, Elders Council, I'll talk about them as Elders Council, was split into a number of working groups. And housing was always something that was well attended. A lot of people were interested in it and had a say. But we determined that what we really need to do was to go out there and prove something in the real world. So we persuaded the city council to give us a house, which was quite a bold step. I should tell you that Newcastle at the time was getting a terrible kicking in private eye because of its high-handed way it had started to demolish housing in the West End without really a huge amount of consultation. It was getting a bad press. So I suspect this was a bit of a carpe diem moment. They needed to refurbish their reputation, and along we came with something which wasn't going to be terribly risky for them. So our premise was that what we wanted to do was to take an empty local authority housing and detail it to be more suitable for an older person. And the city said, yes, okay. They gave us a 3-bedroom semi-detached house, which is very typical local authority stock. And at the very first meeting, they also said they'd pay for the work. That's very nice. So at the very first meeting, I remember it well, an architectural technician came and a housing officer, and we were sitting around, and the architect pulled out 2 plans. This is what the house looks like now, and this is what it's going to look like at the end. Oh, he said, little crumpled faces, as you can imagine. And I can't remember now exactly how the conversation went, but clearly that was not where we wanted to be. We actually wanted to have a voice. We wanted to research things. We wanted to learn something ourselves, but also to, it was about us as a group of people, if you want, building some reputation with the local authority. Anyway, we obviously managed to persuade them to hands off. And older people actually put in 600 hours together on this particular project. We did workshops together. I remember there was a lovely one where we all sat with bits of card and scissors, and we did we made up the house as it was when we were 16. And it was, what was the most important room for you when you were 16? Now, remember, 2 women said, one woman said, oh, I had to share a bedroom with my sister. My bedroom was the most important place. But we are both at an age where we wanted to do our hair and put on lippy and go out and impress young men. And we had to fight for the share of the mirror. And one gentleman, the kitchen was a teeny little place. And we said, really? He said, well, I never went in there. He said, that was for my mother. His most important space was the shed where his motorbike was, because he wasn't on it, he was polishing it. So we began to learn about the importance of space and how it changed through our life. What was important to us now? We also learned about light. We went to the Disabled Living Alliance, and we went up and down on stair lifts, and those sinks that went up and down. We tried all of this gadgetry to think what is acceptable. And what happened was that as we brought forward ideas and we came up with our plan, this was actually implemented. And the house was opened for 3 weeks. A lot of people came, including older people. And the city council learned how to detail a property for an older person. It knew how to do things for someone who had disabilities, but this was much more subtle. And it took that learning away, which it still relies upon. And as a group, what Elders Council learned was older people can be powerful. Everybody got very charged up with that and thought, hey, we can do something. We don't have to just talk about it. We can actually prove things and make a mark. This is a very different focus. This was me in 2015. I think this was discussed this morning. And it's quite a big thing for an academic. What difference does it make? And you think, oh, now there's a question. Our institution wants us to write important papers, and you want to get promoted, and you have a big CV and all those things. And you think, yes. And, what else? And you think, well, maybe you're being overambitious for your work. I think a lot of us working in this space of housing and place actually want to make a difference in the real world. How do you do that? How do you translate your work into practice? So this was me in 2015 thinking, oh God, I've been banging on for years about housing for older people, and we're still heavily reliant on the private sector, which rolls out these little boxes. And once you get your eye in on the architecture of these, you can tell them a mile off, whoa, retirement housing, retirement housing. Overheated, small units of housing, downsized. And you think, what do we think about right sizing? Downsizing also doesn't mean you want to live in a matchbox. This is crazy. So this was the only story that they wanted to hear. And I thought, well, this is not it. I thought there needs to be something different. And I'm just wondering if this is going to play. I bet it won't. Bet it won't. Will you do that? Yes, you will. Oh, you're not doing. No, you can hear it anyway. That's okay. That's all I wanted, yeah. Was A little less conversation, a little more action. That's all we wanted. Now, how do I get out of this? Here and come back again. Oh, I knew I was being overly clever. Right. That's it. Because I remember being at a local conference and saying, you know, it just needs to be different. And somebody said from the audience, well, we need more research. And I said, no, we don't. As I'm researched up to the eyebrows, I said, what we need to do is to push that into action. So I thought, right, girl, step out of your comfort zone. And I think actually, because this doesn't have a happy ending, so prepare yourself now for tears. But I think there is no sin in failure, but I think there's a sin in not trying. So what I decided to do was to bring a group of local stakeholders together, which responds to this quadruple helix, which you may be aware of. The idea is different groups of people have a different view on an issue. They bring different solutions. They've got different resources and different address books. And together you can be invincible, allegedly. So I invited people by name, saying, I think you, like me, want to make this a better city. And at my age, I'm well connected and everybody I know is senior, so that was quite easy. And I'm amazed to say everybody came because I've been having a few sleepless nights. This is a stupid idea, Rose. What the hell are you doing? Anyway, everybody came. At the end of the first meeting, we decided we would build, not research. One of my partners was a housing association. I said, oh, no sweat. Housing, Homes Communities England money, we can bring that to the table. The other one was the biggest architecture practice in the city. I thought, yes. And of course, Elders Council. By 2018, we had become a community interest company with these people as directors. So older people's voice was going to be at the heart of this going forward. Because we were committed to an open innovation platform, this really were our mantras. We thought we wanted to make flexible intergenerational space where people could, if you want, move their walls around. Don't ask me how this is done. I'm the mouth of the project, not the technical side, but I'm told by architects, oh, no sweat, Rose, that's dead easy. So there you go. But we also felt that having a voice was important, that being engaged and being listened to and actually having an impact was going to be really important in our project. So we were really committed to this. There was a massive amount of passion around this. And we had lots of big conversations in community health professionals. We had a seminar with a top kitchen designer. We spoke with middle managers. We had workshops with older people, with people who had little kids, all sorts of different groups of people trying to think about what should our housing be like? How do we respond to real life? So the design was built out of all of that. We got planning permission in 2021 to build 66 units of housing. Brexit. In 21-22, there was a 21% increase in building materials. Ouch. Brexit will not go there, but it just made everything difficult. Materials and, of course, decision-making got slowed down. Eventually, we went out to tender. The tender came back as massively more than the quantity surveyor, who went a very pale shade when the meeting we had. And we did some value engineering. This went on and on. The tenderer had to re-tender. We were at the point of signing and the developer went insolvent. And it was the only developer in our region who could do such a technically challenging project. And you think, ow, the economics of new build at the moment in Britain is just awful. It was really shocking. So I went through a classic bereavement cycle, anger, grief, despair, and very slowly to a position of philosophy, but also thinking, well, we might be down, but we ain't out. So we are still working together, thinking, how do we push our story forward, because we have, as one of my colleagues tells me, brand traction in our region and indeed beyond. So, so I think I take from this, you know, sometimes you just got to step out there, and if it doesn't work, it doesn't. But a lot of people became powerful, were well connected, and I think it was worth doing, though, of course, I would have liked a happy end. A very different project in between those times was senior students, I should explain, in Newcastle. Planning students do 3 years in, a year in paid practice and a year back. This was students at the top end, working to a brief written by Elders Council and working in workshops with older people in a deprived community of Newcastle. And I've never seen help so written on the body before. These were people who were, you know, really had an awful lot of chronic illness. It was attended by many local authority officers, and I put here serious looking people with notebooks who stood behind you and scribbled everything down. And I thought, you could have been doing all this yourself, you know, boys and girls, but clearly what they wanted to do was to see how we did it. So students were terrified. The first session they went in were all kind of, but by the second session, it was, oh, Matt, come and sit with me. Jane, will you come and sit beside me? They'd kind of become, you know, welcomed. Older people were delighted to see them. And students grew a lot from it. Out of that, the City Council accepted the report as a proof of evidence. It increased the community activities in the neighbourhood and increased, you know, the voluntary sector to be doing the same. Tesco, big supermarket, put in a free hopper bus to its big supermarket because older people's shopping choices were really quite poor quality and expensive. So other people kind of came in here. So even from a small project, you could actually make a difference. More recently, this was a partnership between Elders Council, Northumbria University, and ourselves. We worked in 2 typical neighbourhoods of the city, thinking about community resources. I remember talking to one lady and said, who's the most important person in your neighbourhood? And she said, it's me. She said, every day you've got to get up, get your coat on and get out. If you wait for somebody to knock on your door, you could die behind your door. You've got to get out there, get yourself seen and get yourself heard. And I feel this idea about being active, perhaps in your own quality of life. So all of these discussions, we captured them with an artist, which was a nice, fun way to capture this. We had a drama group sat in on these, and on the last session, they all had us drumming and doing all sorts of strange things. They then started to create some songs with us about what they'd heard, and they had a week-long residency. And a lot of older people went to that, and from that was built a play, which then was performed, and a lot of policymakers came to listen to it. You think there's something about using creativity for getting your point across, because everybody's got far too many reports in their inbox. And you think, I'll get round to reading that. And you think, oh, really? And when is that? But there was something about the immediacy of this. Since then, this particular drama group have been working with us on issues about housing, and they made a really nice piece of work called Doorbells, Dreaming of the Future. And this has been used in a lot of workshops as a catalyst for older people thinking about, well, where do I want to move? What do I want to move to? What's my expectation? What do I want from a community? What do I want from my housing? So it became a way of getting people to think about things and to then engage in conversation and start their own future planning. Bringing things kind of up to speed and nearly getting to the end. This is the most recent project I'm involved in, which is not with Elders Council, but this is with University of Stirling, the excellent Vicky McCall. We're doing a piece of work about intersectional stigma of place-based aging. And you think, what? Excuse me? And you think it's about growing older with disabilities and this impact of place and housing. But what is important about this, I think, is this is a big research council funded project. It is working with community peer researchers who are trained. They have a voice on all of the materials which are developed and which then go out. They are engaged in community mapping. They are keeping diaries. They are paid. When they do interactions, they are paid. And you think, right, one of the problems is you expect older people's time to be for free. Oh, really? Why? My time's not for free, neither is yours. Why should theirs? So we treat people respectfully, but we're also developing this living alliance of social landlords and service providers so that the findings from this work can be translated into different forms of practice. And we're all very ambitious for where this might end up. So I'm getting to the end here because Kieran also asked me to think about challenges. Now, this is a terrible thing to say in a room with a lot of academics. I have a lot of papers in my head which I've never written, but I've got the titles. And one of them is called, What Do You Mean Hard to Reach? I've always been here. And, you know, we often think, well, these communities are hard to reach. And you think, get over yourself. What is this? Sloth? Lack of imagination? You have one way of participating with people, and if people don't respond to that, you think, well, they're not interested. Excuse me. Those people in Cowgate would never have come out to something. We had to take things to them, and they were fully engaged and had a lot to say, and we learned a great deal from them. So I think some of this is about making alliances, keeping these in good repair, and using creative methods. I can say that of all the years I've been working with older people, I have had a huge number of times when I have laughed and thought, well, this is great. This has been fun. And I've been able legitimately to say this was work. And I have had such a fun time. So being able to do something, I was talking with Fatima about serious games, finding different ways, challenging ways, some of which is quite challenging to us, to step out there and to do something which could grab people's attention and make them want to do something. I came across this. I don't know whether you can see this from here, but this is from a participatory city, and I'll send a link to Christine. But they've got all sorts of nice ideas about if you want to get people involved, then, you know, think about variety, think about things which can actually make a difference, think about some wins in this. And I'm happy to talk to people afterwards about it. So bringing this, I think housing is one of the biggest areas of our life. Obviously, for the modest wealth holder, it can be the core of your particular wealth, but it could be the arena or the limits of your everyday life. And we need, I think, to provide more opportunity for people to have a voice in this. But in my experience, there's a huge amount of goodwill in local authorities. But particularly in the UK, I don't know how it is for other people. There isn't enough time. There aren't enough people. Local authority officers have been decimated by austerity. So if you want something good to happen, you've got to do it yourself. People are willing to listen, but you've got to have worked it up and take it to them as this is something you could be interested in. This is what we found. Why did we take it forward like this? You can find that things might happen, providing that you have done the work in between. And I think the other thing is, and certainly from my own experience, you've got to step outside your comfort zone. Some of this is scary. When I was doing Future Homes Alliance, I was thinking, oh God, this is going to end in tears. And in that, of course, I was quite prophetic because it did, including mine. But that's not to say it was not worthwhile. Being creative, keeping things grounded, and keep tapping back into older voices. What are we hearing? Are we responding to the challenges that older people have and trying to do something real in the real world? So can I thank you for your attention?
Thank you very much, Rose. This was really a very inspiring talk and really call for action also. I mean, stepping out of our comfort zone is not something we prefer to do, I would say. So, but it can be very rewarding, as we could see. We have at least, well, we have a good time for questions, for discussions. So people who are interested, there's at least one brave person asking the first question.
Yeah, brilliant. Thank you so much, Rose. All of your work is incredibly inspiring, and I know it's inspired a lot of the work that's also happened in Manchester. And it's amazing for me to study in a city where there's so much happening as well, and where Tina and so many people have forged these partnerships. As you might know, in my research, I'm working in kind of low-income community and getting to know what's happening within the community and proposing a project which will kind of work from the ground up, but hopefully also bridge a dialogue with local authorities. But it is a community which has a history of distrust of local authorities, completely legitimately. And I just wondered how you've managed that throughout your projects. For example, when you invited students and you had the local authorities and you had the older people, what promises were you making in terms of respect within the process, but also some outcomes? Because all of my participants are experts at this point in speaking to policymakers, but they never feel they're actually listened to and have been ignored. So bringing them into a room again together, I want to make sure there's a level of respect and that there's something that can be done. So just, yeah, thank you.
I think that's a very good question. Thank you. I mean, we have these problems in Newcastle as well, or not necessarily with a focus on an aging agenda, but certainly I can think about a number of places where there've been a number of waves. It'll be the same in Manchester, waves and waves of regeneration consultation, and you end up with over-researched places, but under-actioned, if you want. And the problem is, as a researcher, that you go into these places and you don't get a fresh response because people have got into when somebody asks me this, I say that. So the kind of the answers are ready cooked, if you want. And yes, I remember through New Deal for Communities, where I was researching the processes, going to some meetings in Newcastle Westgate, as it's called, where basically the community, it didn't come to blows and blood on the ground, but it was extraordinarily hostile because in the past, and you think, well, you had it coming, City Council. In the past, when the city has gone to those areas, it's been to tell people what to do, or that there were rotten parents or whatever, and that they knew better. And yeah, you can't just say, oh, well, we're all friends now. You think, no, it doesn't work that way. People have to let that go. And you have to, when I was a housing officer, I would stand up at public meetings and you think, right, you are now responsible for the sins of the world from the fall of Adam to now. And you've just got to stand and take it. You can't bite back. You've just got to think, yeah, I am respectfully listening to what you have to say. And when you've got that, then maybe we can have this conversation. You've just got to let that go. On issues of aging, those things haven't really been happening in the city. This is all quite new. And certainly for those people in Cowgate, I think their issue was much more that they'd never had a conversation with the city council. You know, they were kind of forgotten areas. And I think it's a good question. What do you promise? Because you can go in and people say, well, why should I? And you think, well, it'll make a difference to your life. And you think, oh, really? Can we just have a real world check about this? You know, how is it going to make a difference? And I think I just wouldn't want to make those kinds of promises. I think being saying what we'd like to do is hear from you how this place works for you. And in my experience, saying, what's life like on your street is something everybody's got a view and can come in with that kind of opinion. And I think, and particularly important in poorer people's areas, that you put on some refreshments. You know, that you've got tea and coffee and a decent cake. And that's all laid out for people, because these are people who are, poor. Let's not varnish it. Making it a little bit of a social occasion. I say, we'd really like to hear what you have to say. And as it is, it was the local authority which then, came in behind that, listening to what was being said and actually managed to deliver on the ground. So I think anybody now who goes into that neighborhood probably has quite a better reception, thinking, oh, when we said things in the past, things have happened. Of course, that just adds to the pressure of that person coming in to be able to deliver something in what are tougher times. Yeah.
Any other people? Any other? Yes.
Thanks, Rose, for the inspiring talk. A lot to think about. I think it was a very interesting contrast to the presentations in the first half of the day, because you really put a lot of focus on the local context and changing the local context, while the WHO frameworks are very top-down, maybe more universalistic. I was wondering if you could speak about how you have encountered such more universalistic frameworks in your work on the ground. How do they connect these macro ideas and your passion to change the local context? And yeah, maybe just to this kind of like contradiction, or maybe these approaches are complementary, but maybe if you have any thoughts about this, it'd be interesting to hear.
I think that's a very good question. I think I'm going to make quite a poor answer to it, in that much of my work is about empirical research, and I'm very action oriented. So I'm always thinking, what's happening here? I tend to not let that get in the way of anything. I just kind of park it to one side, and think, right, what is important in this place? What are the challenges? What's the, for example, if you're working in Newcastle, which is a wee place of only 250,000 people, but you've got the conspicuously wealthy, and then you've got people who don't know where the next meal is coming from, and not necessarily a massive difference in geography between those two groups of people. Trying to understand the local context, and trying always to make alliances with the voluntary sector and older people's groups themselves, rather than take somebody else's word for what's happening here, is actually to get down into those kinds of issues. So I think I just don't pay much attention to to the bigger issue. But of course, in terms of the higher policy framework, clearly issues about funding, all of those things are hugely important for what you can actually do on the ground. But again, I think that's I mean, it was said very clearly this morning about the lack of resources, but if you're in a city which has been stripped by central government, Labour metropolitan authorities in the UK have been savagely stripped of resources, so that many authorities now, they can only deliver the kind of statutory services. So anything which is extra, even things like home care, you now have to be bedfast in Newcastle in order to get a service. So you would have to be able to pay, and you have to pay anyway for that service. It's not free, but you would have to have the resource to be able to buy in the private sector to deliver services to you. So there's an awful lot of unmet need, and it's understanding that, real sharp end. And are there ways in which we can deliver in spite of all the issues of the local authority? Can we do other things which will maybe working with social enterprise or voluntary sector groups to do that? Yeah, so I think always keeping I suppose my eye is on the microscope, never been much on the telescope.
Another thing that I realized when I was listening to your talk was that when I was beginning my academic career, so to say, I was very scared to say something that nobody else has said before. So I felt that I cannot have an opinion. But listening to you, it made me very much aware that it can be very productive to listen to yourself and to use your own imagination, but also your own human reasoning in a way, and try to understand what's going on rather than looking at the theories or at the bigger pictures, but just start maybe your fascination or your research question from your own lived experience in a way. So that I found very strong in your talk and in your career as well. Other questions? Yes. And then I go back to you, Patricia.
Sorry.
Yes.
I was just thinking about the Elders Council that you mentioned, and it sounds
Don't you love technology? Yes, of course. I'll repeat it for them. Yeah. Yeah. Yeah, right. So the question, this is for those colleagues who are online. The question was about how do I acknowledge the contribution of older researchers within, for example, Elders Council, because while they might be having an impact on policy, if I'm writing it up, is it just glory to me and boo to everybody else? What we're always trying to do is to include those names, so that, for example, Barbara Douglas, who was known to Rod Bond, Barbara was the leader of Newcastle Elders Council, and retired about a year ago when she was in her 70s. And she was often, she had, for someone who was not an academic, she had quite a paper trail, quite a CV, because clearly she was a participant in and was often an active writer within those papers, but her contribution and those of other researchers, older people who were active researchers, was also being acknowledged in that, because again, you're just thinking about who we are. If we, it's when I was thinking about the quadruple helix, you think, well, the idea is business brings money, the local authority brings a regulatory eye, the third sector brings what experts by experience, and the university brings research. And you think, oh, get over yourself. Research happens everywhere. Research happens within business, within the local authority, within communities of older people who want to get out there and have some proof and then take it to a policy provider. I mean, Elders Council have done lots of work about shopping zones, about older people's views about parks. They've done some quantitative research as well as qualitative and photo elicitation, a whole lot of different things, as well as working with drama groups and older people getting to the stage to talk about things. So again, people stepping out and doing something that's creative, but in ways of getting their experience out to a bigger audience. But I agree that in terms of being an ethical person, needing to acknowledge that contribution, without which, of course, my publication history might be a little less. So thank you for your question. There was someone, I think this lady over here.
Yes, Patricia.
Yeah. Mm-hmm. 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 I think that's a good point. I think, whoa, sorry, yes, I need to tell you Patricia's question here because we're running without microphones. Patricia was just echoing Pippa's earlier question about when older people meet policymakers. We might imagine that the power is all with the policymakers, but in many of these situations, and you may have been in them as well, older people are extremely well versed and perhaps more knowledgeable than the policy officers. And I've been in situations where policy officers have been incredibly intimidated by the incredible wealth and expertise of older people and thinking, oh my goodness me, I'm never going to understand this as much. So, and saying that, you know, these things, in spite of conversation and passion, can run up against brick walls. So what are the other points of pressure that might be brought to bear? From my experience, I think stepping away from the local authority, and I give you an example. Actually, this doesn't have a happy ending either. Oh dear, it's real. Oh no, it's days of woe, I'm afraid. A co-housing group started in Newcastle a few years ago, and they're still recruiting members. And they really wanted, the city council was very supportive of that. There's government money to support co-housing. But you know, it's a long trial. People can talk for a long time. I think this group have talked for 8 years. So you've got to be in it for the long haul. It's not a quick win. So they engaged private sector architects, a really great company who are interested in sustainable things and don't shy away from the unconventional. They managed to find a developer who was very keen on this. They've got planning permission. They've got a site, and you think, whoa. So you think, right, you're not working with the local authority. You're not expecting them to be able to step up to the plate and suddenly start to build housing. You're not even working with a housing association in the social sector. What you're doing is probably exploring a bit of a mixed tenure model and thinking how you're going to do that. I've just heard it this week that a developer has said, look, this is not economic, and they've just walked away from it. And you think, oh God, so those people, they've got a site, they've got planning permission. So what they need to do now is to find somebody else who'll take this on. And I suspect what they might need to do is go back into the social rented space and start talking with a housing association. But so I think Smythe's been able, as with My Future Homes Alliance, trying to prove something outside in another arena, then brings a message back into the local authority that there's something different happening in this place, and they can start to get behind it and can start to support it, you know, even start to write these things into their policy. Let's look at their standards. Let's look at their processes. Let's try and promote co-housing in our city as a viable way for older people to exercise agency and have reciprocal ways of supporting each other, which is what people wanted from this particular project. So that might be a bit of a ducking answer in that, you know, when you come up against a brick wall, try walking around the back and see if there's a door open around there. Don't just keep banging your head on the wall, because that's not necessarily going to work, because these people are under tightening and tightening sorts of pressures. It's not getting any easier.
Yes, Christine.
Yes. Yes. Yes, this is a question that's come in from online about how can we address the time lapse between, sorry, what was it? planning and completion. Well, if you are central government in our country, you say, well, planning is just a big problem and we need to reform it. And you think, yes, anyway, this is not what this session is about, but I can get quite passionate and annoyed and full of bad language on how this is a complete misreading of the situation. But I'm not sure there's any easy answers to this. I mean, we might say I mean, I don't think planning is a perfect system in Britain. I think it has its issues, but you either believe in people having a voice in planning issues so that things go out to communities and people will speak in favor of it, or they're going to speak against it. And you either think that democracy, that right to have voice is important, or you think it isn't. We get into a zoning system, you can develop and off you go. And you think, much as it is frustrating, I am still an upholder in that people have a right to talk about the validity of a project within their particular neighborhood. So I'm not sure we can do much about it. My particular set of woes on Future Homes Alliance was made worse by Brexit. So all meetings with planning went online. There was a big time lapse. And then we had a massive price escalation in building materials, and woe followed upon woe. But I think that was, I don't know, it was just the difficulties of time. If we had been sooner out of the block, we'd been sooner into planning, maybe we would have been on the ground and breaking a bottle of champagne on the front door by now. But it was not to be. Right. Kieran's asking a question there from the floor about communities and older people's groups within those communities lobbying for resources. And if you want the tension between their desire for resources and the way, though, if I'm capturing this correctly, in the way that those needs might be seen by others, or reinforce, yes, that some areas might be stigmatized. I don't, maybe we're kind of quite lucky in Newcastle. There seems to have been, and you would like to think the Elders Council have had a shape in refashioning this idea of older people, which may or may not be the case, is that a lot of people now in local government are much more concerned with getting out there and understanding the needs of the community from the community's point of view. I mean, we can, obviously, you can look at statistics about older people and think about, you know, what is the level of health? I was saying that in Cowgate, you know, terrible health needs. I've never seen a group of people who might need a taxi to go like 300 yards from their home to where there was a meeting because they couldn't walk that far. People had leg ulcers and all sorts from diabetes and had really, really poor health. So if you were looking at that through a medical lens, you would see that there was a massive amount of need. If you looked at that from a community response, what people wanted was simply to have, you know, as people everywhere, a quality of life. What they wanted was to be able to get a decent shopping choice, even if they themselves were not able to go, someone was going for them. They wanted to have things to do to make their life meaningful, and they wanted to have sources of support, which is, you know, common to all of us. So when resources were being pushed into that neighborhood, I think there was an understanding that this would be on older people's terms, addressing needs as they saw them, while not letting anybody off the hook with what we need is a doctor's surgery, which is well located, which actually also happened, because that was an interesting conversation. Where do you go for your GP? And people's lines were all over the city. You think, good grief. People go all over the place for healthcare because there was nothing, which was terribly near. So being able to bring those essential services to them, but also then seeing that needs were not just, if you want, of the body. It was so, this is going to sound a bit grandiose, but it was also of the spirit. The people needed to be seen as more than a bundle of medical conditions. They needed to be seen as people who might have spiritual needs, the need for fun and laughter and community and all of that, and to be able to respond to that, which might in itself be beneficial in terms of health and well-being. So it could come round, if you want, in a different kind of way.
Christine.
Right. I think this might be one for Tina. A flying squad from Micro project, right. Right, so somebody online asking about a flying squad, which is interesting. I might need the questionnaire to unpack that a bit. From micro projects to what? Go and home modifications, right. Okay. I don't know. What do you think, audience? What do you think about that? I'm going to put it to you. Right. What would a flying squad do? They would go out and do practical things in people's homes. Well, I have seen things happen, but it's not been about housing. This was New Deal for Communities in Hartlepool. Every now and again, the council, Hartlepool, would cordon off a street. And this was in response to local need. There was a flying squad of officers would come in. These were local authority properties. They would paint the housing. They would renew the lighting standards. They would, any planting boxes and things like that, they would mend them, plant them, redo them, and then they went away, having left that street looking absolutely fab. And you think, oh, and then local youth development workers would come in and they would do things like street basketball. So things happened for young people in that place. So that was a kind of flying squad where a coordinated group of local authority people came and just blitzed an area and did something in about 48 hours. So there's that kind of thing. And you think that it takes a bit of money. I'm not sure you could do that now, but also takes, I think, a little bit of imagination, coordination and listening. But they were able to do that sort of thing. There's no reason, I think, why you couldn't perhaps do that in people's homes, but there's the issue about how you're going to pay for it. So I'm imagining that these people would have had some kind of, you would need an assessment, wouldn't you? What do you need in your house, Mrs. Smith? I need this, that, and the other. Right, okay. I think it sounds like a good idea. Yeah, if they want to start it, I'll be right behind it with a support letter. No, I think those, I mean, you know, I suppose at the heart of that is the idea that sometimes you've got to wait a hell of a long time for things to happen. And certainly from my experience, if you get an OT to come and do an assessment, this sometimes quite a while. You think, well, how's the funding going to get in place? You've got to find a builder who's going to do those things and all those things, by which time somebody's need might have changed. So I think taking the waiting out of wanting is always a difficult thing. And I suppose it was also to the previous question about planning permission. You can sit down and knit quite a few sweaters between, you know, getting your permission and actually things happening on the ground and completing. It can be a long, slow kind of process. And I think ways in which you could shortcut that would be great, but they do depend on resources of people, and they also depend, sadly, on the interest of, on availability of money, which isn't necessarily in good supply.
There's one more question in the audience. Is there another question online, Christina? That was it, and that's the last question. Okay. Yes, go ahead.
Should the care for be
Okay, this is Rod asking if the Care Quality Commissioner should be part of this ecosystem of people, or should they be avoided? Okay, can I put this back to you? What would they bring to a conversation? Mm. Mm-hmm. Yeah, yeah. Mm. Right. Mm. Is that, sorry, for people online, Rod's just saying that as more care starts to come into people's homes, would that person bring that kind of quality assurance eye on what's actually happening within people's homes? Correct me if I'm wrong, and you've got much more expertise on this than me. Is that currently something that the Quality Care Commission actually looks at, or are they only looking within a care home? Right. 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 Okay. Right. Rod's just adding there that the Quality Care Commissioner tends to confine their authority, if you want, to what's happening in a care home, not to what's happening in somebody's own home. But the question is on the table about whether that should happen. Whether it should be that person, I don't know, but I think the issue of what happens within somebody's home is clearly very critical. For people who are not aware of the British situation, you can get this, which I think is awful. It's you know, where is the humanity in this? That someone might be coming to offer home care to you, and they give you 15 minutes. What can you meaningfully do for another human being in 15 minutes? Or I think what was being said this morning is it might be entirely, you know, maybe somebody is wearing adult nappies or needs help with some intimate task. So, you know, you throw them a good morning, and then you do that, and then you're out the door. You think, oh my God, you know, if that's how I'm going to end my days, and press the pillow over my face. I just think that's just, you know, it's just awful, isn't it? And you think this is driven entirely by money. And you know, the person, the idea of person-centered care, you think this has all become a charade. It's all about cookie cutting, isn't it? How much can you get out of the limited budget that you have? And you think we obviously need a fresh conversation, but then you still get back to the big question in the room, which is, where is the money coming from? How could this be paid for? The current model clearly doesn't work. There's a lot of people who are in need. There's a lot of people in unmet need who aren't getting any care at all. And the care that some people get is perfunctory. So yeah, if that would be a solution to it, then yes, I would love to have those kinds of conversations. Whether it's the right person, I don't know. I don't really feel qualified to say yeah or nay, but I think it's an avenue for exploration, and let's not take anything off the table till we've had a look.
Thank you very much. We have to stop here, but we have a coffee break now soon to continue the discussions. This is also the end of the public part of the training program, so I would like to thank to the online colleagues to join this training session. I would like to thank the audience for the questions, for the engagement, but last but not least, of course. Thank you, Rose, for a very inspiring talk, very much. Thank you. So the people here in the group, they continue after the coffee with Lisbeth and Kieran on how to find the right literature, and another session afterwards. But thank you.